of Society of Fetal Medicine, Marathwada Chapter, Solapur Obstetric and Gynecological Society, and Sholapur Chapter of Maharashtra State Branch of Indian Radiology and Imaging Association, MSBIRIA, I, Dr. Anshu Sharma, extend a warm welcome to all the faculties and delegates on the first day of the scientific program of this third quarterly meet of SFM. Friends, today is a fantastic opportunity to learn from the best in the field. It's my pleasure to welcome our experts in the field of prenatal care and diagnostics who have traveled all the way to Sholapur to share their knowledge and experience in this live workshop. A warm welcome to Dr. T.L.N. Praveen, Dr. Anirudh Kulkarni, Dr. Shilpa Satarkar, and Dr. Sujit Konkar. We are indeed honored to have all of you here with us today. We are sure your expertise will provide us a comprehensive learning experience on the latest advancements and techniques in fetal ultrasound with strong focus on practical applications. On behalf of the entire organizing team, I express my gratitude to each and every one of you present in this wonderful auditorium of Balaji Sarovar for taking time out of your busy schedules to attend this live workshop on a Saturday afternoon. A special warm welcome to all the young enthusiastic residents who have a big role to play in shaping the future of fetal medicine. Friends, this workshop should be a success only with active participation and wholehearted commitment of all of you with plenty of exchange of ideas during this session. Let us make this a fully interactive session. I hope this workshop will foster new connections and inspire everyone present here to continue pushing the boundaries of what is possible in the field of fetal ultrasound. Surely it shall deepen our understanding of fetal well-being and leave us with the wealth of knowledge to apply in our practice. So, let's get started and make the most of this wonderful opportunity. I wish you all an enjoyable and productive workshop and a memorable experience with us today. I have with me Dr. Sujit Konkar, Secretary of Society of Fetal Medicine, as my co-host today. To begin with the first demonstration of the day, we have Dr. Shilpa Satarkar. Dr. Shilpa is Vice President of the Society of Fetal Medicine Marathwada Chapter, practicing ultrasound since last 27 years. She is Director of Antarang Sonography and Color Doppler Center, Aurangabad. She is an ex-associate professor at GMC, Aurangabad, and ex-professor at PVV Medical College, Ahmednagar. She is National Coordinator of Samrakshan Team of IRI working for pre-eclampsia screening to reduce perinatal mortality in India. Special interest in pancreatico-biliary ultrasound and obs and gynae ultrasound. I extend a warm welcome to you, ma'am. Ma'am will be demonstrating 11 to 14 week NT scan to us today. And here is Dr. Sujit Konkar, who will be taking us through this journey.
Good evening, dear friends and colleagues. Questions are expected from your side while the examination is taking place. So I request Dr. Shilpa ma'am to start the examination. So what is the strict criteria for mid-sagittal section?
What is the?
Strict criteria.
For?
Mid-sagittal section, proper mid-sagittal section.
Okay, so a proper mid-sagittal section, it has a very specific pattern recognition. So in that pattern recognition, what we need to see, either you go from front to back or from back to front. So in the front, you should see the nasal bone, and the nasal bone should be like, it should be the first, it should be, there will be an is equal to sign, which, okay, so this is the near thing which I could tell you. So this is the tip of nose and this is a part of nasal bone. Here the skin of the nose should be seen. And then when we come from this section below posteriorly, here we see the palate where this is the maxillary bone and this is the vomer bone. You see a small hypoechoic line in this area. And then this part should be Actually it is exactly not the mid-sat section. At times you may slightly, it will go slightly para-mid-sat, where you can see the choroid plexus here, but if you get an exact mid-sat, then this area will be hazy, I think. And then we have a pattern recognition where we see 4 echogenic lines and 3 hypoechoic bands. So the the echogenic line, first echogenic line will be that of the bone, and then the hypoechoic line will that be of the midbrain brainstem. The second bright echogenic line, this is the echogenic line which is the posterior aspect of the midbrain. This is the fourth ventricle, the second hypoechoic band, and it is also called as the intracranial translucency. This is to be measured from inner to inner aspect. This intracranial translucency is the fourth ventricle, which is limited here by the choroid plexus of the fourth ventricle, and this is our cisterna magna. So these 4 echogenic lines, 1, 2, 3 and 4 echogenic lines and 3 hypoechoic bands, 1, 2 and 3. So this is the brainstem, this is the IT, and this is the cisterna magna.
One question is there, ma'am.
Yes.
What is the significance of measuring brainstem and brainstem occipital bone distance?
So tomorrow I will be covering that in my first trimester anomaly scan. So what happens, that measurement basically is important for the first trimester detection of the open neural tube defects. So what happened in open neural tube defect, the CSF gets drained out through the open neural defect, which is somewhere below in the lower spine, and therefore what happens, the Arnold Chiari type, and then what happens, the CSF in these fourth ventricle, it drains off. Once the CSF drains off, what happens, the this brain stem, it becomes widened and it comes towards this occipital bone. So this brain stem becomes thickened, and the brain stem to occipital bone. So the brain stem now, as this CSF is leaked away, the brain stem comes here. Therefore the brain stem to the occipital bone distance decreases, and the brain stem itself becomes thickened. So that is an sign in which we can like we can say that yes, this is a possibility of having open neural tube defect in the patient. So this is the brain stem to BSOB distance here.
Thank you, ma'am.
Yeah. Zoom कमी करा. Okay. So now after this midbrain section, we will try to get a section. So it's a section of face. So whichever section I will be getting, I will be showing you the things. So this is the coronal section of the face, where here you can see the orbits here. So these are the orbits here. Yeah.
Orbits with echogenic lens is also seen there.
So yeah, so this is the orbit here. This is the orbit, and here right this circular thing which you are visualizing is the lens here. And then arrow kadun taka. Scroll.
You can see the retronasal triangle also in this section.
Yeah, and this is the retronasal triangle. So what are the structures which form this retronasal triangle? So this is the part of the hard palate here, a part of the maxilla, and these are the nasal bones which form the retronasal triangle. So when there is a cleft palatal thing, though this part is difficult to visualize in the first trimester, you can see a gap here. And then second thing is what we are going to see, these are the mandibles here. So these mandibles have a space in this, so this is called as a mandibular gap sign, and which is a normal thing. You should always see a gap here in this mandible, and when the mandible is recessed back as in micrognathia, we see the whole mandible as a line here, and this mandibular gap sign becomes absent, and that indicates that yes, this mandible has regressed posteriorly, and then it is forming a single line. So this is the premaxillary triangle, it is called premaxillary triangle in the second trimester, and the retronasal triangle in the first trimester, and this is the mandibular gap here which you can see. Now let's try if we get sections of the brain. Okay, whatever sections I will be which we are getting, we will be describing now. So in this new ISUG guidelines for the first trimester scan which were released in this January, What they have asked us to evaluate the fetal limbs also, where we have to evaluate 3 sections of, we have to look for 12 bones of both the together of total upper and the lower limbs. So here you can see that this is the one lower extremity, where this is the first, this is the femur, this is the tibia fibula, and this is the foot. So all 3 segments of all the 4 limbs, therefore we have to this 1 and 3. So yeah, this we have to see these 12 bones, then we have to see the movements, and then we have to also evaluate the alignment of the foot with this leg. At times in the first trimester, the diagnosis of CTV becomes very difficult if it is mild CTV, but if it is very significantly there, then we can also diagnose that. And then we also have to look for the movements of this. So if there is fetal arthrogryposis or akinesia, fetal akinesia sequence is there, FADS like thing is there, we can diagnose that.
Silpa, how confident are you to give a diagnosis of CTV in the first trimester?
No sir, it is recommended as CTV, you can suspect, and then again you have to repeat that at 16 weeks, and then we have to come to the diagnosis.
Excellent. That is one most important message that it has to be carried. Not that every time you can see a CTV, talipus in the first trimester. Quite often you may suspect, but then it has to be confirmed by doing it at 16 weeks before you label it as a talipus equinovarus deformity. Thank you, Silpa.
Then these are the upper limbs, where again you have to look for all the 3 segments, and then the hands also. If you go for TVS, in fact first trimester can be done on TA, TVS, or both, like you can use both the things. I prefer doing TVS, where you can very well demonstrate even the 5 fingers also. Here also we are able to demonstrate the 5 fingers. Here you can see 1, 2, 3, 4 and the 5. And in the first trimester the hand is maximum of the time open, or majority of the time we can see the completely open hand. Therefore counting of fingers become very easy in the first trimester, and that we should always do in the first trimester, because again in the second trimester and things, there can be always a fist which is closed.
So you tell us that we have to look for the digital abnormalities in the first trimester.
Yes sir,
right.
That is easy to look in the first trimester.
Because they are open.
Yes. And then we come to the abdomen. So again in the abdomen we have to look for the section of the stomach, where we have to demonstrate the stomach. We can see stomach right from 11 weeks, even in early that also. And with the help of this stomach, then we have to take the AC in this section. And the most important thing is that here we have to see for the anterior abdominal wall and the level of the cord insertion. The demonstration of the cord insertion becomes very important, because we have to look for the intactness of the anterior abdominal wall, which can be done in the axial section or even on the this serratal section like this. So the insertion of the cord at this area is very important, and then here you can see if there is any defect here, the gastroschisis or the omphalocele or other limb body wall complex can be very well demonstrated.
So insertion of the anterior abdominal wall cord will help us to rule out the possibility of supra-umbilical, umbilical and infra-umbilical anterior abdominal wall defects.
One question is there.
Yeah.
How will you define situs in this 13-week scan?
Yeah, we will show you.
Basically situs, see now the section is really becoming better and better. So this is so this is how we, whenever we want to take the measurement of NT, we have to first take the proper section, mid-sat section, where the position of the neck should be neutral. Neutral position means neck should not be hyperextended or it should not be hyperflexed, because hyperextended neck will increase the, it will pseudolly increase the NT, and hyperflexed neck will decrease the NT. Therefore, the neck should be in the...
How do you say that it is in the neutral position?
Oh, yeah. In the neutral position, so these area, yeah, this is the part of the neck.
A good pocket of amniotic fluid between the chin and the upper thorax.
Upper thorax.
That is what is very, very important. That tells you that the fetus is in a neutral position. Very nice.
And then to take the measurement of the NT, we have to go for the inner measurement.
That is better. Yeah.
So you have to take a plus caliper.
Every machine has got an auto NT also, but then I think most often we prefer to do it ourselves, and probably we can check with the auto NT.
Yeah. So while measuring, you have to use the plus caliper, and the horizontal limb of the caliper should be just dipping in this white part and the upper part of this white image here, and then we have to take the similar to the at the upper end also, and this is our NT. We should wait, and we should either call the patient on the second day later on.
Yeah, I understand that it's very easy to do the invert the image, but then that is not accepted in the
common
guidelines.
problem day-to-day practice.
Now we are trying to take the ductus. So as we know that ductus is a vessel, the umbilical vein, it enters the anterior abdominal wall, and then it traverses up towards the abdomen, up towards the liver, and then it joins with the left portal vein, and when the left portal vein takes a curve from that area, this ductus venosus originates and it joins the IVC at the infundibular area, and then it goes in the heart. So this is the area where the ductus venosus is seen. So now ductus venosus, as it is an oblique vessel, it has to be taken always in the sagittal scan, not in the axial scan, because this being an oblique vessel, the length and total thing can be visualized very well only in the oblique scans. If it is means in axial section, you will not get the proper area of this ductus venosus being a oblique vessel. So we have to always measure that in the sagittal section.
And as you say that it should always be in the right parasage.
Yeah, it should be in the right parasite.
Wonderful, wonderful.
Yeah.
Beautifully done.
What should be the gate for this?
Yeah, we have to use a minimum gate of 0.7 or 1 millimeter when we are when we are taking the ductus venosus. So here you can see we have used the gate of 1 millimeter.
Why so? Why not 2? Why not 3? Sujit.
Very small vessel, 2 millimeter vessel.
Exactly.
So not only that you can ask, we can also ask you questions.
Yes, sir.
So it being a very small vessel, we have to take this measurement, and now here is the spectral waveform where you can see that this is the S wave, this is the D wave, and this is the A wave, and in this case the A wave is not visualized here, the A wave appears to be absent here. So when do we say that the ductus venosus flow is abnormal? In two ways, when the A wave is either absent or A wave is reversed, then the ductus venosus flow is said to be abnormal. So in this case, we feel that the ductus venosus flow is, at present it is showing that the A wave is not visualized, but when you see like this, you have to confirm it twice or thrice before giving this. In this part of gestation, she is hardly 11 weeks, 2 days or something. So at this time, the compliance of heart is yet to appear, therefore ductus venosus absent or a slight reversal or tricuspid regurgitation at this stage can be a physiological thing which is because of a non-compliant heart. So if we feel like this, we have to again repeat the scans in these patients.
One question about ductus venosus waveform interpretation. Is the increase in ductus venosus PI is as important as absent A wave?
No, come again. No, your question we didn't understand.
Sir, increase PI in ductus venosus.
PI, yeah, definitely increased PI itself indicates that there is a decrease in the atrial contraction, isn't it? Increased PI is another way of saying that the ductus venosus is abnormal. Okay.
Does it carry
is that what you wanted?
Does it carry in significance in aneuploidy risk screening?
Aneuploidy, does it carry any significance?
No, in aneuploidy, basically what we are interested in ductus venosus is when do we call ductus venosus flow abnormal is when there is a reversal. Just absent or decreased A wave has no relevance as far as the first trimester scan is concerned. The relevance in the decreased and absent A wave is only in the growth restricted fetuses, whereas in an aneuploidy it is only the reversal of A wave that we give importance. So and then increased PI. So these are the two things that we give importance, but not the other things.
Okay, thank you, sir.
Yeah.
Sir.
Yeah, please.
Ma'am just said about the length of the ductus venosus.
Yeah.
Is it important?
So technically it is good that you can assess the length also because you know where you are going to take the sample. That is very important, isn't it?
Yeah.
See, as such the ductus venosus is a very small vessel. It is about less than 2 millimeters and 0.8 millimeters in diameter. And only way that you are making out the ductus venosus is because of the aliasing. So, I mean knowing how much it is not, there's nothing wrong in knowing that information.
But we don't measure that actually.
We don't every day measure it in our day-to-day practice.
It is basically just that this aliasing help us to identify the ductus venosus.
Yes.
And the maximum area of aliasing we should identify, and we should keep our cursor exactly at the maximum area of aliasing so that we get a proper waveform there.
Thank you, ma'am.
Can you start with the CRL once? Because all these.
The second ultrasound marker, now we will just see if we can take CRL. Actually, she is not giving a proper CRL. But when we have to measure the CRL, it should be in a neutral position, and we have to measure. This is not a proper section, but just for the sake how to take measurement, I am telling you. This is the crown. We have to measure from this area to the rump, which is here. So, this is the area where we measure the crown rump length.
I have a question for the audience. Okay, you have an anencephaly. Then what are you going to do? But you have to give a gestation age because the obstetrician would like to know which way to terminate the baby. Anyone from the crowd?
If anybody wants to answer, there's a mic that has been kept in the center.
Pardon me?
You can just walk to the mic and please answer the question.
No, I couldn't get, sorry.
She is asking the audience.
Oh, okay. So there is an anencephaly. What are you going to do?
Sir, is it femur length?
No. It is called as the URL. This is the upper pole to rump length. Because in the anencephaly you don't see the cranium. That is the reason why you can't call it as a crown rump length. But you still can see the brain parenchyma dangling there. So you call it as the upper pole to rump length, URL length. So that is much more appropriate than the femur length. Quite often femur length is not very suggestive of the accurate gestational age. Okay, I think she is now again taking one more patient of 11 to 14 weeks. And actually now what we try to do is that we call this as a 45 to 84 millimeter scan rather than 11 to 14 week scan. And all these things, particularly when you take into consideration the nuchal translucency, tricuspid as well as the ductus venosus, they are all the ultrasound markers which will give you a likelihood ratio of a risk associated with aneuploidy. Remember, every pregnant lady, every fetus has got some amount of risk, and that inherent risk is what is called as the a priori risk, that is the gestational age of the fetus as well as the maternal age put together. Now we need to identify some markers which can tell us that there is a likelihood ratio which will be associated with it, which gives us the fetus specific risk. Right? That's how you try to evaluate it. Now, the most important thing which we should remember here is all these markers are gestation age dependent. That is the reason why an accurate measurement of crown rump length is very, very essential. So, in order to do that one, you have to magnify the image to almost 80% of the screen, and you need to have a neutral position, you need to have a supine fetus, and then only you can do the measurements. Now, another one important thing I would like to ask the obstetricians who are there in the crowd, quite often now, how often do you ask for a NIPT? Please shout. I mean, I was told that it is an interactive session, so as much as you can ask me questions, I can also ask you questions. Hello?
Anybody wants the mic? So
Quite
the
often
answer,
do you use,
not
very rarely
routinely.
use? No, I have asked you a very straight question. How often are you asking for an NIPT?
Rarely.
At what gestation age are you asking for an NIPT?
Around this time only 11 to 13 weeks if the markers are off.
For example, now what we have is, see, once you do an NIPT, this nuchal translucency, all these things are redundant, isn't it? You really don't need to have it. Because NIPT tells you almost 99.8% specificity, and the false positive rate is hardly 3. So that is the reason why now what we have started doing is what is called as the pre-NIPT scans. That is, whether the NIPT need to be done or not. Suppose you have a non-viable fetus which has been detected in the pre-NIPT scan, there is no meaning in doing an NIPT. Similarly, if you have a twins, you would like to have a traditional screening rather than the NIPT. So these are various things. Suppose you have an anomaly, you will do a test which is pertinent to that anomaly. So that is the reason why we now develop the skills of doing what is called as pre-NIPT scan. And remember, over a period of time, probably we may even give up doing all these ductus venosus, tricuspid as well as the nasal bone, because once you do an NIPT, there is no reason why we should do all these things. Do you agree with me? Hello? Yeah, please. If there is someone who wants to, see, this is a discussion, because unless we discuss, we will not get to a point.
Sir, NIPT is very expensive. Our patients can't afford NIPT.
No, listen, I don't agree with you. Suppose if you do an NT scan, how much do you charge? Not asking you personally. Suppose take me, I charge, let us say, 4,000 rupees. And if I get a double marker, that will be another 2,000 rupees. It is 6,000. Your NIPT is 8,000. But it is non-invasive. You don't need to trouble yourself and trouble the patient. She's getting beautiful images of the fetal cranium. Oh my God, it's very nice. It's like textbook.
These are the TVS images.
Yes, TVS images.
And here you can see that these are the choroid plexus which are filling the
lateral ventricles.
Yeah, lateral ventricles, and this is the midline falx, which is very classically seen here.
Yes.
Yeah, and this is the midline falx here.
So, what did you deduce in the sense, if you see the midline falx nicely seen here, so you can rule out the possibility of a fusion abnormalities or cleavage abnormalities. You call it as cleavage abnormalities, right?
And then this anechoic structure is the aqueduct of Sylvius. The aqueduct of Sylvius is never seen after the first trimester. It is seen only in the first trimester. And these are the cerebral peduncles. The side things are the cerebral peduncles here. And then
in this section, one sign is very much talked about, that is crash sign. Can you explain it?
Pardon me, I couldn't get you, sorry.
Crash sign, sir.
Crash sign.
Yeah, we will show you.
Okay. So,
there is no crash here,
yeah.
but we will tell you what crash sign is.
Yes, sir.
Get these. No. So the crash sign is basically this one. The distance between the aqueduct and the occipital bone should not be more than 1.7 at 45 weeks of gestation or 45 millimeters of crown rump length. If it is lesser than that, that means the aqueduct has moved closer to the occipital bone. That is what is called as the crashing of the aqueduct to the occipital bone.
Distance.
Okay, so when it crashes to the occipital bone, it indicates that there is a Arnold-Chiari type 2 malformation where there is a traction of the posterior fossa structures. As there is traction of the posterior fossa structures, the aqueduct moves closer to the occipital bone, and that is exactly what crash sign is. Am I clear?
Yes, sir. Thank you, sir.
So here you can see this is the aqueduct here, and now we are taking the measurement of aqueduct to the occipital bone. So it's around 2.5 millimeters.
Yeah. So it is absolutely normal. It is more than 1.7.
And that can also be seen visually also. And the second thing which, this is beautiful section.
See how nicely she has done it. This is a perfect aqueduct.
Yeah.
You can, that is the aqueduct, occipital bone. See, the peduncles are diverging, converging towards midline.
Yeah.
Can you see the convergence of the peduncles?
So if you draw a tangential line from here, these are the cerebral peduncles. This is the borders of the cerebral peduncle. If you draw a tangential line from here, this will go here, this line will go here, and the cerebral peduncles are being converged. But what happens in open neural tube defect, as all this CSF drains off, these cerebral peduncles and the aqueduct, it goes and crashes against the occipital bone, and this shape which is rounded now, it becomes a square shape when it goes here. And when it goes like this, these structures, these borders of the cerebral peduncles, they become parallel to each other.
Yeah, that is what is called as the parallel peduncle sign. Okay. Can you show us the BSBOB? Try and show us in case if it is possible. Now, one beautiful sign. Hold it. Yes. Freeze it. Now, can you see the fourth ventricle? Show the fourth ventricle. Beautifully seen fourth ventricle, choroid plexus, nicely seen choroid
the
plexus.
choroid plexus.
You can see the ductus, I mean the connection between the fourth ventricle and the cisterna magna, and that is open at this stage of pregnancy. Which please remember that it is not abnormal. And then the size of the fourth ventricle is again important, because once it is more than 19 millimeters, you have to very strongly suspect the possibility of aneuploidy.
And here again you can very well see this premaxillary triangles and this, and yes, here.
Beautiful, beautiful.
Here you can see the abdominal section.
Tell us about the situs also.
Okay, but
Please sit and show us.
yeah, for determination of situs, TVS is never should be used in the first trimester.
Yes.
That you have to remember, and I'll again demonstrate the situs in the transabdominal. I just slipped it. It's just
No, but
slipped on.
then here also, I may say that the apex of the heart is corresponding to the stomach. That is more than enough, because whether it is a situs inversus or a situs solitus, if as long as these two are coordinating with each other, the possibility of a cardiac abnormality is very, very low, because the inversus is just a mirror image of the situs solitus, isn't it? So the basic concept is to identify the apex of the heart and see whether that is corresponding to the stomach or not. I am not saying the laterality of the fetus. Laterality of the fetus is very difficult on transvaginal.
So here the cardiac apex.
Beautifully seen, and then you can see the stomach.
Here the cardiac apex is here, and then we are visualizing the stomach here.
Yes.
So the cardiac apex and the stomach are on the
Same
side.
side. Can you follow that? Yes, no,
Yes,
please, you have to shout and tell us, because we don't know whether we are conveying what we wanted to. Please.
Yes, it is seen very nicely.
Yeah.
Not you, you will see.
And then this is the spine which we are able to visualize. We can, even spine, vertebral anomalies, we can identify this. And then again, as we said, the limbs are very properly seen. Here you can see the hand.
One question regarding fetal cardia. What are the minimum sections which are required to see in first trimester anomaly scan?
So
About
the new
heart.
guidelines, these new guidelines have given some 14 sections for that to evaluate the fetus, and now they said that what is the minimum thing is there, you should always go for more than the first trimester basic things.
About fetal heart.
About
Fetal
fetal heart,
heart,
okay.
okay.
Right. So this third ventricle.
Yeah, this is the third ventricle.
Yeah, this is the third ventricle.
Beautifully seen. And then she has been demonstrating nicely the butterfly sign,
Yeah.
right? So whenever there is a butterfly sign, you can see that the whole of the lateral ventricles are filled with the choroid plexus. Now, whenever there is the ratio between the choroid plexus and the lateral ventricles are altered, that is, normally in the first trimester, you should see more of choroid plexus, less of CSF. If it is more of CSF and less of choroid plexus, you know that you need to suspect that there is a possibility of a ventriculomegaly.
Because in first trimester there is no size measurement for the ventricles like 10 millimeter or like that. Here you have to take the ratios, the area, the length, and then the other
Area of
ratio.
the choroid plexus
Area of choroid plexus to area of the lateral ventricle, length, and third is the volume of the things.
Is it possible to visualize cerebellum at this stage? Cerebellum
Cerebellum.
at this stage?
Cerebellum. Cerebellum, yes, you can, but then
In
it's
near
not-
14 weeks, we can hardly see a part of
very,
it
very
near
small
14 weeks,
cerebellum.
but not at 12 or 13 weeks.
No,
It's
I
very
don't think
difficult.
so. I don't want to convey a wrong message, because see, there are some people who have diagnosed Danny Walker also, but then it is a very limited experience that we have.
It is not part of 11 14 week scan.
Pardon me?
Looking at cerebellum is not part of 11 to 14 week scan.
Yes, yes, yes.
Thank
So
you.
this is the fetal heart.
Fetal heart nicely demonstrated the 4-chamber view and
Magnify karana.
magnified glass. So basically, when we try to evaluate the 4-chamber, the fetal heart in the first trimester, there are 4 most important things that I would like to look for. One, whether the apex of the heart is corresponding to the stomach or not, that is one. Second is to demonstrate the 4 chambers in the gray scale, put the color Doppler on and show that the color Doppler shows that there is a good inflow tracks, that is the atrioventricular flow, then do a 3-vessel view by using a color Doppler. If you can demonstrate these 4 structures, along with it, if I can make out the axis of the heart, I am most often sure that at least at about 85 to 90% of the times we can rule out a cardiac abnormality in the first trimester. I think the baby is not happy with Shilpa.
It's not giving.
Actually, I tell you, you have to talk to the baby. You have to please it. You have to console it.
Okay, so this is a 3-vessel trachea view. Very well you can see.
But then color, can you put the color please? And then, right.
So the colors are not set.
No.
So at least we can show in black and white.
What is the PR? It is 9 point.
In grayscale also it is looking very nicely.
Yeah, in grayscale also it is looking
Right.
the dash dot and the things like that.
Good, very good, very good.
And then in this section again you can demonstrate the 3-vessel cord very clearly.
Insertion of the cord is
Insertion
seen
of the cord and
beautifully.
the
See that one? Can you see the insertion of the cord? So nicely seen.
This is the insertion of the cord, and then we have to look for the 3-vessel cord here.
Can we diagnose single umbilical artery at this stage?
Yes, you can diagnose a single umbilical artery in first trimester. Your setting should be very proper to diagnose the single
But
umbilical.
then don't get surprised in the second trimester you find both the vessels.
Yeah.
Quite often it happens. So don't get disappointed, because the one which is not completely open may not be seen at 11 to 14 weeks, but as the gestational age progresses, the other one also becomes opened up, and then in the second trimester you do find a 3-vessel cord.
That means we should not be in hurry to diagnose single umbilical artery at this stage.
Yes.
Thank you, sir.
Here again you can see the fetal spine very well, and then when you look at the fetal spine, you have to see the contour and the shapes of this fetal spine. If you suddenly see some angulation here, then that will point out towards some vertebral anomaly, or then it can point out towards the open neural tube defect, discontinuity. And this is the lower limb which we can very well see.
See the fingers she has demonstrated so beautifully. Can you magnify that? Just this, reduce and put it here. Still. Right. See? Oh my God, she's saying hello.
So the baby is now happy with me.
Now it says enough.
And then in the first trimester again you have to look for the placenta. Majority of the times the placenta is low lying. Whenever the placenta is just covering the internal os, then only you have to.
Cervix is seen beautifully here.
And you can see the cervix. So this is how the.
Nice. See, can you see? Appreciate the cervix. So beautifully
This is complete the
demonstrated.
cervix. This is the complete cervix here, and here you can see the lower edge of the placenta which is just covering the internal.
Covering the. 1 second. Shilpa, can you see this? What are these? Can you put the color on? Nothing. Yeah, it's okay. Yeah, I was carried away thinking because it's a low-lying placenta, probably associated with vasa previa. That is what is called as the dot line sign. But anyway, it is nothing there.
Filamentous insertion of cord associated with.
Nice. Anything else you want?
Can you label this as placenta previa?
Can you label this as placenta previa? No, actually you have to just mention in your report that the placenta is just covering the os, because now we know that nearly 90 to 95% of the patient the placenta will definitely migrate. Just the gynecologist should be alert that she may have us bleeding and spotting, and just for counseling purpose this is required, so that the patient won't come in the midnight and wake up you like radiologist or the gynecologist that, oh, I am having bleeding. You can counsel the patient that yes, placenta is low lying and at times you may have some spotting. Don't be scared with that spotting, and then she need to take counsel the patient regarding what care she has to take if the placenta is low lying, that she has to be in abstinence, and then she has not to elevate heavy weights and like this simple things which the patient needs to follow.
One question about nasal bone. Do we measure nasal bone in first trimester?
No, we say presence or absence of nasal bone as far as the first trimester is concerned. Only in the second trimester we call it as present, hypoplastic, absent.
Many times at 11 we're able to see the nasal bone. What should be?
Pardon me. I couldn't get you. Sorry.
It is many times we are not able to see nasal bone at 11 weeks, 11 or 12 weeks. How to proceed for this? Do you directly label at absent nasal bone?
No, I mean, first and foremost thing, if you are sure about your technique, yes, you can. But if you are not sure about your technique, better to ask her to come back again. Now, I think she will show you the nasal bone. The baby is up, showing its nose.
So she is the case with absent nasal bone, I think.
Any questions from audience, please? Questions are welcome.
See, the whole workshop is for you people. Please, unless you interact, there is no fun in it. Sujit and every one of us know everything about this. They are just asking us to tease us. So it is for you to extract as much information as possible. Give them a mic, no, to the audience. Or Sujit, if you know names, please call them. Then they will start asking.
So does it take a long time to do an NT?
It takes long time sometimes. Sometimes if you are lucky and the baby is helpful to you, you will finish off within no time. But if it is not in an appropriate position, it will definitely take very long time, and there are multiple times we will ask the patient to come back again. You make them sit, ask them to walk, you ask them to take food, then come back and all those things. I mean, all sorts of tricks we try to do.
So it's normal for everyone to take a long
Everyone.
time?
I mean, there is no exception in it.
Then I'll just tell you how to take the tricuspid valve measurements.
How to look for tricuspid regurgitation?
Yeah, that is what I'm trying to tell you.
See, first and foremost thing, you need to get a good 4-chamber view. Unless you get a good 4-chamber view, your sampling. No, I think baby is not in an appropriate position.
Gate thoda sa mota kare. We have to put the gate across the valve, the tricuspid valve. One end should be in the right atrium, the other should be in the right ventricle, and then we have to.
No, it's not. It's not in an appropriate tangent.
Yeah.
This is actually when you ask someone to do if you are angry with someone, you ask them to do a workshop on 13 weeks.
And that's probably Anirudh has done with me. Because I was first told that mine was the workshop on color Doppler. Okay, but no issues.
That is debatable now.
Okay.
No, he had so much of confidence in you that you can do it,
Yes.
whichever the way it is.
We are not getting the proper.
For tricuspid regurgitation, the heart should be in apical position.
Pardon me, come again?
For evaluation of tricuspid regurgitation, the fetal heart should be in apical position.
Yes, apical 4-chamber view.
Yeah.
Apical 4-chamber view, wherein you can definitely see the tricuspid valve, and then place the gate, sample gate across the tricuspid valve. One limb of the sample gate should be in the right atrium, the other limb should be in the right ventricle, so that you are trying to assess the atrioventricular flow across the tricuspid valve. So then only you can demonstrate the tricuspid regurgitation.
So if again the baby is giving persistently basal heart position, can we take tricuspid flow?
Pardon me, so come again, sorry.
If the heart is persistently at basal position,
Heart is in the tip of the heart. The heart is in the basal.
persistently basal position.
Apical basal. No, I mean you can take, even then also you can take. It's not that hard and fast that it should be only apical 4-chamber, but you should get the tricuspid valve properly demonstrated. See, she has demonstrated.
Yeah, this is the aorta here, and at in the first trimester the kidneys become, visualization of the kidney becomes at times difficult. So indirect way of visualizing is you have to visualize the aorta and then demonstrate the renal arteries here. This is the renal artery which is going on the on the opposite side, and this is the one which is going to the.
So you have to take a coronal section. See, beautiful, very nice. Excellent. See that one. Can you see these kidney renal arteries?
Yeah, this is beautiful.
Give
Yeah.
her an applause. She has demonstrated so well. Excellent, excellent.
Similarly, in this view, we can very well demonstrate the
Huh.
the demonstration of urinary bladder is also very important in the first trimester. So, urinary bladder you have to identify by the visualization of these umbilical vessels here. On both sides, this is the vessel, this is also a vessel. If I decrease the PRF, then definitely we will get whole of this vessel. But demonstration of bladder becomes very important. If you just see this insertion of this cord here and you are not able to demonstrate the bladder, then wait for the bladder to get visualized. Do not complete your evaluation without visualization bladder, because that will once you say that yes, bladder is seen, you will rule out the bladder extrophy and the other abnormalities. So, the demonstration becomes very important.
So how many of you are doing 11 to 13 week scan? Hands up. Sujit, count them.
This is a 3 vessel cord, very well seen.
What Sujit? None of them are doing?
Yeah, around 15 to 20. 20.
20 people.
20 people.
Around 20, yes.
So all these 20 people, are they doing the same method or are they following something else?
I think they are following FMF guidelines.
Which
They are-
guidelines?
Fetal Medicine Foundation.
Fetal medicine, FMF guidelines. Whether whichever the guidelines you follow, it doesn't matter. See, the markers cannot change. Where is the gate?
Gate. Pulse. Angle. I have to change the angle. Angle to this side.
Right. And then increase the gate size, sample size. 3.
No, it has become too wide, sir. थोड़ा कम कर.
Yes. Take a sample.
This is something.
Yeah. You have the A wave, E wave, and then the ventricular contraction also very nicely seen. But only when you find the regurgitant wave, you can find more than 50% of the systole being occupied by the regurgitant flow.
So here
Normally
you get
also you do get a whiff of regurgitation, which is normal. But if it occupies more than 50%, then you call it as an abnormal or the tricuspid regurgitation.
And you should go more than 60 centimeters per second.
Yeah, of course. Yes, you are perfectly correct. So anything else, or shall we move?
Any questions from audience? Please.
Sir, this is regarding nasal bone.
Nasal bone, please.
Sir, absent nasal bone, hypoplastic absent bone, nasal bone, or unilateral absent nasal bone. Can we comment on in first trimester?
First trimester, we will say only absent or present. There is no hypoplasia. Yes, unilateral absence is also known. Unilateral absence will have the same likelihood ratio as a bilateral absence. But in the first trimester, I will not give importance to anything more than presence or absence. That's it.
Thank you, sir.
Measurement is not to be taken in the first
No.
trimester.
Anything else? Oh, if there is nothing, then shall we move on to the next case? Say, at least say that, no?
Sir, apart from aneuploidy screening,
Preeclampsia screening.
uterine artery
Yeah,
and cervix.
See,
Yeah, I am going
yes,
to
yes,
demonstrate
she is
the
doing, she
same.
is doing.
Yeah, uterine artery will be discussed in Doppler section. The patients of Doppler in third trimester.
Yes.
Please tell something about cervical length, sir. Cervical preterm screening. So, you know,
In the first trimester, I don't think many, we do get requisitions for the cervical canal length in the first trimester, but then what is the importance given to this cervical canal length in the first trimester? I am asking a gynecologist, obstetricians. Do you really give importance to it?
it is important to, if there is history of preterm delivery in the
No,
previous
that
pregnancy.
is okay. No, on a regular basis. Suppose, for example, the patient is sent to me and there is no, the priming. Do you expect me to take a cervical canal length for all of them? Because that's an important thing, because what happens is how much
Yeah,
of importance we give to it is what is important, because quite often we don't give much importance to the cervical canal length at the first trimester. Do you agree with me? No one is agreeing, or at least contradict me. No. Now, okay, anyway, see this one. This is the uterine artery sample she is taking. Ask her not
तू
to
ना
move.
डोकं हलवू नको आणि हलू नकोस, शांत पडून राहा. शेवटचा पार्ट चालू संपत आला तुझा. So to identify the uterine artery, first we have to go over the cervix in a partially distended or adequately distended bladder, and then you have to identify the internal os. So this is the internal os here, and then we have to just tilt the probe, putting the color box to just one side, and so here you can see the left uterine artery. Now we have to put the sample gate over the uterine artery, and then we have to take the
Sample gate of 2
millimeters, and the angle of insertion should
See
be
how nicely.
less than 30 degrees.
30 degrees.
And
So
then-
nicely got.
Yeah, and then we have to
Measure.
take the measurement.
Auto.
measurement.
Auto measure? No? You don't have auto can? Yeah. Yeah, beautiful.
Yeah. So
So
the-
it is 1.16.
Yeah, the PI is 1.16, and a single-sided PI is never useful. You have to take the measurement from the left side. Similarly, the right-sided PI, you have to take the measurement, and then you have to
Calculate
the mean. And if the mean is more than 95th percentile, then it is a abnormal uterine artery PI. And if you screen only with uterine artery PI, you are going to detect only 48% cases of the preeclampsia. You are going to miss 50% cases, 52% cases. So there should be a combined screening for preeclampsia, where the maternal characteristic, the mean arterial blood pressure, and then the uterine artery PI should be combined. If your patients are affordable, you can also go for the biochemical markers like PLGF and PAPA also in the first trimester.
Now,
this is how the uterine artery PI is.
Yeah. Now she has said that taking just the uterine artery PA is not really useful, because you will miss 52% of the cases. How many of us are taking mean arterial pressure for the maternal mean arterial pressure properly? Because proper taking of the mean arterial pressure is what is very, very important. If you are not going to take proper mean arterial pressure of the mother, it doesn't make any sense. How many of you who are busy in your OPD can spend some time or train your people to take a proper this thing? Okay, so now the question is, do you believe in giving a universal aspirin? Yes, no? Huh? No. Then are you doing mean arterial pressure properly? If you say yes, then I'll ask you, how are you doing it?
Heart magnifier.
That is a big debate that is going on, whether to use a universal aspirin or to really do it, because FMF has very clearly stated that unless you do all the parameters taken into consideration, that is the maternal characteristic, particularly the ethnicity, smoking, as well as alcohol, and then the obesity, BMI, as well as the mean arterial pressure. So unless you take the beautiful
yeah, this is the three vessel view.
Yeah, nice, very nice.
So this is the three vessel view, where you can see that this is the.
Can you show the trachea also there?
Yeah, this is
yes,
the trachea.
Beautifully seen.
Trachea. This is the pulmonary artery, and this is the aorta. This is the dash and dot. Once you see this dash and dot, they say that the major arteries have a crisscross, and that you are going to rule out parallel flow tracks.
Thank you.
And this is the 4-chamber heart, which you can see very clearly here. I think it color kadum taka. Color no.
Thank you.
Magnify. So this is the 4-chamber heart.
Yeah.
Even like in the first trimester, we can calculate the cardiac axis also here. This is the this is the septum, interventricular septum, and then we have to calculate the same way which we calculate in the second trimester. So we will demonstrate you how to calculate the axis.
Okay, anything else, or shall we give a big applause to Silpa? Wonderful job, wonderful job. She has done a great demonstration. We have learned a lot about it.
Sir,
Yeah.
There is a question whether
Yes.
can we diagnose diaphragmatic hernia in 11 to 13 weeks NT scan.
Yes.
Yes, we can diagnose. See, it is just the same as that of the second trimester in the sense, first and foremost thing, you need to demonstrate the mediastinal shift. Once you have demonstrated the mediastinal shift, remember when you take a sagittal section of the fetus, basically what we have is that the echogenicity of the lung is more and the echogenicity of the abdominal viscera is less. Whenever there is a disparity and then whenever you find that the echogenicity of the lung has become less and you don't clearly demonstrate the demarcation between the echogenic lung and the abdominal viscera, you have to strongly suspect the possibility of a diaphragmatic hernia. So, mediastinal shift plus this are the two factors which will definitely tell us that there is a possibility of a diaphragmatic hernia. Anything more you want to add?
So the new guidelines have the new guidelines which has come in January 2023 about the first trimester anomaly scan. They have given it as a good point to demonstrate the diaphragms in the first trimester, and they are very beautifully seen in the first trimester. The diaphragms are absolutely beautifully seen in the first.
Do you
trimester.
see the diaphragm properly, or is it because of the contrast you see the?
It is because of the contrast.
Contrast. You don't see the diaphragm.
Yeah, it is because of the contrast, we are seeing the
That's
hypoechoic.
exactly what I said.
line
The
of
lungs
diaphragm.
are echogenic, the
Yeah.
abdominal viscera is hypo.
Yes.
Thank you, sir.
Sorry.
It was a truly enlightening experience. Hello. Ma'am, it was a truly enlightening experience, easy to understand, captivating, and Praveen sir's running commentary made it also feel so simple and easy to understand. Ma'am, thank you so much for the demonstration.
Thank you.
It's an honor and privilege to introduce TLN Praveen sir. He has been at the helm of affairs in IRIA, IFUMB and SFM and runs the Abhishek's Institute of Imagiology at Hyderabad. Recipient of Certificate of Excellence for being a team member of the first coronary angioplasty in India in 1985. Also, recipient of Indra Priyadarshini Award and Lifetime Achievement Award by Telangana State Branch of IRIA, Appreciation Award by Foxy, and Ashok Mukherjee Memorial Award for Original Innovative Interventional Work for Cytogastric Stenting in 1993. Author of a chapter on ultrasonography, knobs and gynae, and another on advanced imaging in the textbook of radiology, and also having published many articles. He's reviewer of Journal of SFM, Indian Journal of Radiology, American Journal of Sonography, and is also a member of editorial board of IJRI. He is a student of Rangaya Medical College and Osmania Medical College, Andhra Pradesh, interested deeply in diagnostic and interventional ultrasound. He offers advanced courses of ultrasonography to
Madam, I think it's enough.
post-doctoral students
It is becoming toxic.
every month since last 35 years. Sir, please let me
Okay, sorry.
passionate not only about fetal well-being but also for running and hiking. And also we are seeing how passionate he is for teaching, how interested he is to make us understand, how willing he is to answer all types of questions, however silly and simple they are. And we are also seeing how easily he answers the complex questions and simplifies the solutions to make us all understand and satisfy these quests. So we are keen to learn from you the much awaited anomaly scan.
Thank you, Ma. Thank you for the introduction, and I think you have overdone it. That many people have achieved, that's not a big deal. But then let me get to the point. Today, I'm really interested in showing how I do an anomaly scan in the mid-trimester. Remember, when we are trying to do a mid-trimester anomaly scan, there is one issue of guidelines or a protocol that has been developed, what is called as the 2-sweep 20 plane guidelines.
which will be used to evaluate various congenital abnormalities of the fetus. So, let us follow it. What is this 2 sweep? 2 sweep is the initial sweep, which is actually what is called as the survey sweep. That is, while applying the gel, I just move my transducer all around the maternal abdomen, so that I will know what exactly, where exactly the placenta is located, how much is the liquor, what is the position of the fetus, is it breech or cephalic, and also try to evaluate whether there is any gross abnormality which I can pick up on this cursory glance. That is the initial sweep. So, I think this baby is really wonderful, and she is, I am really lucky to have her today. Thank you, ma. And then see this. Now, when we try to evaluate after the first survey sweep, then we start evaluating the fetus in a structural pattern, that is going to the skull, then the spine, then the thorax, then the abdomen, then the limbs and all, face and all those things. But then remember, one need to be opportunistic, because as we see, the evaluation of the fetal face is again a very tricky situation, because you can see the fetal face sometimes when the fetus is prone, there is no way that you can get the fetal face properly. So, one of the most important thing is that whenever I get the fetal face in an appropriate position, I finish off evaluating the fetal face. The second important thing that I would like to do is to evaluate the fetal heart, because once the fetal heart is not in an appropriate position, there is no way that I can really demonstrate the fetal heart. Now, so keeping these two things in mind, let us start off with evaluating the fetal face. Now, see in this particular section, this is what is called as the lip nose section, where you can beautifully demonstrate that is the tip of the nose. You can see the nostrils here. Yeah, see that one? Those are the nostrils, nicely seen. Can you see the nostrils? That is the philtrum. And then I have the lip, upper lip. You can see the upper lip, and then the lower lip, and then the chin. So, I will show you once again. See this one, right? Beautiful, right. Now, you can see the upper lip, that is the mouth, that is the lower lip, that is the chin. So, this is one section that I would like to see as far as this is concerned. When I see this one, I will just turn across at right angles and try to get the nasal bone. See this one, slowly I am nudging myself in such a way that I can get the nasal bone beautifully demonstrated. See this one now. Okay, sorry. No, let me do it first. Okay. Now, you can see this one. Yes? No, this is not good. Yeah, while doing this, I am also focusing on something else. Can you see this one? I am getting this nice sagittal section of the fetal head. When I get the nice sagittal section of the fetal head, it freezes this, oh sorry, I am sorry. This is the what is called as the trihorn ventricle, where there is a parasag section, and in which, can you see the image clearly?
Yes, sir.
Yeah, and then I am just nudging it towards the midline, trying to get the corpus callosum. See this one? See, I'm jumping. I'm not trying to follow certain guidelines, in the sense whatever is coming to me in an appropriate way, I'm trying to evaluate those structures, right? So, as I'm not getting it here, I'll leave it there, I'll go back. So, this is what you have to learn in order to save time. What you need to do is, first and foremost thing, try to evaluate the face and the heart. In case when you are trying to evaluate the face, if you get it properly, it is well and good, or else start evaluating other structures. Now, here I am not able to, I got the nose section very well, and then I am trying to get the orbits. Now, these are the orbits beautifully demonstrated. I am saying myself beautifully, because no one is saying. Okay. Yeah, lens is also seen here, beautifully seen. Okay. I will show you in a better way also. See that one, beautiful lens, right? Can you beat this? It is staring at you, saying that you are not asking questions.
So, when this echogenic ring becomes absent,
yes,
we say that it is a calcified.
Yeah, calcified. And then not only that, you can see that the distance between the interorbital distance is very important. This interorbital distance, that is in between the two orbits, should accommodate one more orbit. If it is not accommodating one more orbit, or it is closer to each other, then you call it as hypotellurism. If it can accommodate more than one orbit, then you call it as hypertellurism. Am I clear? Now that is one.
So most of the times when we are evaluating the eyes, one is easily seen, the other one is not so easily seen.
Correct, correct. You are correct. Yeah, that is a practical problem that you have to nudge and try to get both of them as far as possible. Now here, this is again nicely seen. Can you see the metopic suture? Nicely metopic suture is seen. Who is making sound? I think Anuruddha is making sounds. Yeah, here this is the metopic suture. Okay, right. So that is the metopic suture. Those are the eyelids. Can you see the eyelids? Right? Yes, no?
Yes, sir.
Appreciate.
Sir.
Yeah, that is the premaxillary triangle, nicely seen. And you can see that there are small, zoom it, yeah.
So when to call hypotelorism and one hyper?
Hypotelorism is when you cannot accommodate more less than, when you can not accommodate, no, go back to normal, yeah. When you cannot accommodate one orbit. See, normally you should be able to accommodate one more orbit in between. Agreed?
Okay.
Yes, no?
Yes, sir.
Right. If you cannot accommodate one more orbit, that means both the orbits are closer to each other, then you call it as hypotelorism. Now, this is the premaxillary triangle. You can see the base of the triangle formed by the palate. These are the zygoma, and that is the nasal bone on one side. I am not very confident about the opposite side because see this one. Yes, 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 yes.
So, sir, it's more of eyeballing, or are there any measurements too?
For what?
So, for the hypo and hypertelorism.
Hypotelorism, no, it is most of the time. See, now tell me, you tell me whether you can accommodate one more orbit or not. You tell me, then we will see. I am getting both the orbits 1 second, and then you tell me whether you can accommodate one more orbit or not.
Yes, sir, we can.
You can, isn't it? You got disgusted with me and you said you can. Yes, you can. So it is normal. Okay. Then now that is about the premaxillary triangle and the tip of the nose. You can see the profile, facial profile, where you can beautifully demonstrate the nasal bone also. Here you can see this is the nasal bone, that is the tip of the nose, that is the palate, that is the omer. This double line appearance is extremely important to say that you are exactly at the mid-sagittal position, and that not that you are taking the zygoma or the maxillary bone as the nasal bones. And then you have the upper lip, that is the mouth, that is the lower lip, and that is the chin. And now you draw a line from the frontal region to the chin. It shouldn't cross the chin, and if it is not crossing and the chin is behind, then you call it as a retrognathia. Am I clear?
Yes, sir.
Very good, fantastic. So this part of it is over. So face, almost we have finished everything.
Sir, one question is there, sir.
Yeah, please, please.
Will you demonstrate palate, sir?
Palate, yes, yes, yes. I'll show you. That's a good question. So now, see, this is the premaxillary triangle. Now, what I am trying to do is, I am trying to rotate my transducer in such a way. See this. Now you can see it beautifully.
Yes, sir. Yeah, it's seen very nicely.
Yes. So what did I do? This very simple, and then if you know this trick, it is very easy to demonstrate. First and foremost thing, get the sagittal section of the face.
So can you please place the arrow at the palate?
I'll show you, one second. Now see what I am trying to do is, I am trying to see the palate from below the neck, that is through the mandibles, to the soft tissues of the mandibles. I'll show you again. See this one. Now you can see it, right? See that one? Right? Can you see this? I'll show you. Yeah. You can see the tongue also. See the tongue? Can you see the tongue?
Yes, sir.
Yes. Okay. So these are all the things. Now, I mean, in certain situations where you can even see the uvula. Yeah. No, it's gone. Yes.
Yes, sir.
Yes. See that uvula?
Yes, sir.
Beautifully seen.
Is equal to sign.
Right. Is equal to sign. See that? It has swallowed. This baby is in love with me. Very nice. So this is beautiful, okay?
So now, it's the other way around. It's your love for the baby.
I think Anirudh has chosen a best case for me. Thank you, Anirudh. And now let us get back to the other structures. Let us finish off. Now I am not worried. No, I am worried because I have not finished the fetal heart, isn't it? So fetal heart, when I want to do, this is the fetal heart, 4-chamber view, right? Can you see? I'll show you one most important trick here. Now I am seeing the fetal heart. Show the frame rate. Show the frame, no, to the marker. See that frame rates are 30. Agreed? Can you see that?
Yes, sir.
Right. Now reduce this thing, sector angle. Right. Now see what is it is. What is the frame rate?
66, 60.
Wow, 60, isn't
Yeah,
it?
yeah.
So, whenever you are trying to evaluate a dynamic structure, you need a good frame rates. The more the frame rates, the better the visualization. That's how you are going to optimize the fetal echo evaluation. So, now I have optimized it in such a way that beautifully I can see the fourth chamber. But I am not interested in this. I again would like to do a what is called as the sequential segmental evaluation, which I am going to take you through tomorrow. But basically before that, I will show you here. This is the abdominal section. Freeze please, freeze. And now beautiful demonstration. Here see, you can see the vertebral body. Agreed?
Yes,
you
sir.
can see the aorta. You can see the inferior vena cava. You can see the stomach. You are agreeing with me?
Yes, sir.
Right. So, aorta is always either anterior or to the left of the spine. Inferior vena cava is always anterior and to the right of the spine. This is extremely important relationship that we need to demonstrate in every patient. So, when you start off evaluating the fetal heart, you start off evaluating the fetal heart by taking the transverse section of the fetal abdomen, demonstrating this relationship. That is one. Second important thing is, here itself I would like to assess the laterality of the fetus. That is, what do you mean by laterality of the fetus? The laterality of the fetus is nothing but to say which is the right side of the fetus and which is the left side of the fetus. There are many ways that have been described, but one way which I normally follow, I will tell you, that is, I first and foremost think I ask three questions. One is, what is the presentation of the fetus? Two, what is the lie of the fetus? Three, what is the relationship of the fetal spine to the maternal spine? I need answers for that. Now, in this particular patient, we have a breech presentation, longitudinal lie, and we have the spine here that is to the right of the mother. Am I clear?
Yes, sir.
So, you imagine yourself in that way. So, which is right and which is left of the fetus now? So, this becomes the left and that becomes the right, isn't it?
Right, sir.
Okay, agreed?
Yes, agreed.
Right. So, that's how you are going to assess the laterality. Once I have assessed the laterality, I am fine. So, the situs can be easily demonstrated. Now, I release it. So, what did I do? I got the fetal stomach. So, this is the left. I have agreed that it is the left, and now I am going up and taking a sweep to the fourth chamber view. This is the fourth chamber view, and that is particularly corresponding with the apex of the heart. So, I am very sure that it is a situs solitus, that is the left sided the apex and left sided stomach. Okay. Now, in this one, again this is the fourth chamber view. Here of course we try to evaluate various morphological features of the chambers, sizes of the chambers, presence or absence of four chambers, and then the interventricular septum as well as the intraatrial septum, particularly the foramen ovale, that is the flap of the foramen ovale, which is very nicely seen. And once you see the flap of the foramen ovale, the chamber into which it projects is the left atrium, and then you can see the pulmonary veins on either sides. Now remember one most important thing here, not only that grayscale, I always would like to put the color and demonstrate, because sometimes small ventricular septal defects can be easily missed only on grayscale. So that is the reason why. This is a little more, yeah, beautiful. Now,
so before you go on the heart, so for the situs, do we need some mnemonics?
Pardon me, I couldn't get you, sorry.
For determination of situs, do we need any mnemonics?
Mnemonic, I don't know. Is there any mnemonic? I don't know. I'm an old fellow, I don't know mnemonics. I mean, so what mnemonic you want? Is there anything? If you have something, please tell. I have no problem.
Okay.
Come on.
So the CLU and BLU, that was very common between us.
CLU, PLU. Instead of remembering that,
it's CRU and BLU, sir. CRU and BLU.
Please explain so that we will follow that.
Sir, C is for cranial presentation, means vertex.
Oh, okay.
CL and U. The L is for left side up.
Okay.
And BRU, the CRU and BLU, right side up and left side up.
And now we will ask the audience, have they been confused well? Okay. Now, anyway, so that's a good thing. I mean, I really didn't know that. I'm sorry, I don't know about it. but this is actually, see now, can you switch off the color? Now, see, this is actually what is called as the lateral 4-chamber view. You agree with me?
Yes,
and
sir.
lateral 4-chamber view is the best view to demonstrate the ventricular septal, intact ventricular septum. See, you can see the intact ventricular septum beautifully demonstrated, the thickness is nicely mentioned, and you can also see the atrioventricular valves, and then can you see the relationship? See the atrioventricular valves, and then the morphology also beautifully seen, wherein this is the moderator band, and then you can see the septal insertion of the cardiac tendineae, which is suggestive of a right ventricle, a smooth walled left ventricle. There is no cardiac tendineae. The cardiac tendineae is attached to the free wall of the ventricle. So these are the factors which tells you, and not only that, the posterior most chamber is the left atrium, closer to the aorta. This is what is called as the area behind the heart. You should always remember to see in the 4-chamber view, and the anterior most chamber is the right ventricle. Is that clear?
Yes, sir.
Yes. Now, once that is done, then I will slowly move in such a way that I can see the fifth chamber. That is what is called as the 5th chamber. That is the left ventricular outflow tract. You can see the left ventricle. That is the aorta which is coming out of the left ventricular outflow tract. And then here it is wonderful view where if you can demonstrate this is septo-aortic continuity. This is the septo-aortic continuity. If you demonstrate the septo-aortic continuity, you can rule out the possibility of a membranous portion VSD. That is one. Second important thing is this septo-aortic continuity will have an obtuse angle. If it becomes acute angle, then you know that you are dealing with a overriding of aorta. Am I clear here?
Yes, sir.
Very nice. And then in the same way, there is a aortomitral continuity or the mitral leaflet also. So these are the things that you are
So
going
please
to look
demonstrate the two arms of the angle.
Pardon me?
So when we say obtuse and acute angle, so once again please demonstrate the two arms of the angle.
Yeah, see this one? How beautifully seen?
Yes, sir.
Yes, it is nicely seen.
Very nicely seen. And you can see the valves also. Very beautifully seen valves. Can you see the valves?
Yes, sir.
Yes, beautiful, right?
Opening and closing of the valves, nicely
Very
seen.
good, very nice. And then now I come back to the right ventricle. That is slowly I am getting to the right ventricle. You can see the right ventricle, and you can see I am trying to get the short axis view, but instead of short axis view, I am directly getting the 3-vessel view. So you can see the 3-vessel view, beautifully seen.
Yes, sir.
Where you can see it is the orientation is left to right. Left is the pulmonary artery, aorta, and then the superior vena cava. So the alignment is left to right. The sizes also, the left is biggest, aorta is smaller than left, and then the SVC is smallest. And the flow direction also is always towards the same direction of flow in both the great vessels. So these are all the things that you are going to look for as far as the fetal heart is concerned. Now once I finished off the fetal heart beautifully, I mean there is no second thought about it because I have seen everything what is required. And now not only that, and one small thing which I am very really fascinated is to, can you put the color on? Yes, no, that is the 3-chamber. Can you reduce, that is the brachiocephalic. See that one? Can you see the one which is crossing across?
Yes, sir.
That is the brachiocephalic, and just above the brachiocephalic, can you see this particular area, okay? This particular area is the thymus, okay? So
Yes, sir.
these are the things that you are going to look for as far as the fetal heart is concerned. Am I clear now?
Yes, sir.
Any doubts now?
Sir, can you demonstrate normal right subclavian artery? Because RSI is so much discussed in various
I'll
conferences.
show you. See this one. Now this is the 4-chamber view. The 3-vessel trachea view. Now, when you take ARSA into consideration, ARSA is one which is an abundant right subclavian artery arising from the, come on, arising from the descending aorta, isn't it?
Yes, sir.
Hello.
Yes, sir.
So it has to cross and go anterior to the trachea. Is it correct?
Yes,
Okay,
sir.
agreed.
Yes,
Yes,
sir.
no?
Yes, sir.
Yes. So now I am trying to demonstrate the descending aorta. Now I am going up gradually, and then when I am going up gradually, I can see that one, right? I am not having any branch there. This is how I am going to demonstrate. See this. Now that is the 3-vessel. At this stage, I would definitely see if there is an aberrant right subclavian artery crossing the trachea. I will show you the trachea once again. Can you see the trachea here? Yes, no?
Yes, sir. Yes.
Yes,
So
sir.
once you see the trachea, If there is a vessel which is crossing across, then you know that it is a upper right subclavian. Is that okay?
Yes, sir.
Yes, sir.
Okay. So this is as far as the heart is concerned, and at the same time in this one you will see the lungs which are echogenic on either sides engulfing the heart, and then I will take a sagittal section, and that is the diaphragm. See how beautifully seen because of the contrast between the two abdominal viscera and this thing. And now I am coming down, and when
One question about heart, sir.
Pardon me?
One question about fetal heart. Some streak of fluid is seen surrounding the heart, that is mild pericardial effusion.
No.
So
I
what
will
is
tell
the
you,
significance of
normally,
that?
Physiologically also there will be some amount of pericardial fluid. But when do you want to call it as abnormal? When you call it abnormal when this streak of fluid which is there, it crosses the atrioventricular groove. If it is going above the atrioventricular groove, then you call it as a pericardial effusion, which is pathological. If it is not crossing and if it is less than 2 millimeters, then you call it as normal or a physiological pericardial fluid. Am I clear?
Yes, sir.
Yes, sir.
Right. Now coming down, that is the stomach, okay, and then I am see that beautiful. These are the adrenals. Can you see the adrenal here? Yes, no?
Yes, sir.
Yes, and this adrenal is not seen because there is a shadowing. Okay, that is stomach. Right. So that is the adrenal, and see beautiful. See that one, peripheral lucency and central echogenic area. Now I am going down into these. Those are the kidneys.
Yes, sir.
And whenever I see the kidney, I turn around and see whether the sagittal sections of the kidneys are also seen nicely. See that one. Can you see beautifully coronal sections?
Yes, sir.
Yes, sir.
Right? No, you are saying yes, the audience are not at all reacting. Hope they are not sleeping, isn't it?
No,
You have
sir.
not given them lunch, no? Have you given them lunch?
So we started at 3:30.
Oh, see the renal arteries?
Yes, sir. They are seeing nicely.
Beautifully seen. Yeah? Good. Okay, then see that one, and then look for the anterior abdominal wall insertion. Can you see the anterior abdominal wall insertion?
Yes, sir.
Yeah, here. This is the anterior abdominal wall insertion of the card, and then I am gradually coming down. That is the gallbladder. Can you see the gallbladder?
Yes, sir.
And can you see the umbilical vein and
Yes.
the porto-umbilical junction?
Yes, sir.
And then I put the color on here so that I can demonstrate the ductus venosus. Yes, yes, beautifully seen. Yes, right? Agreed?
Yes, sir.
Agreed.
Right.
Sir, in AC section, what if you don't see gallbladder?
Pardon me?
What if you don't see gallbladder?
No, I mean, I would definitely like to see gallbladder. The reason is, of course, there is nothing like not seeing gallbladder should be mentioned in your report. That's what I mean. In the sense, if you don't see the gallbladder and if you don't mention it and tomorrow it becomes a biliary atresia, you can be legally responsible. So, it is always better to look for the gallbladder. If it is not there, please mention in your report at the time of examination gallbladder could not be imaged.
Is it similar to looking at the small stomach bubble or low distended gallbladder, urinary bladder? Would you like to wait for some time to feel it?
I think so, we need to wait. But then I think gallbladder waiting may not help us. We are waiting for the gallbladder to fill. Stomach and bladder is definitely going to make any difference. See this one now, even without the color, I know that it is a 3-vessel card, isn't it?
Yes,
you
sir.
can see the vessels skirting the bladder. Now I put the color on. See, beautifully seen. Yes?
Yes, sir.
Right. So, that is the 3-vessel card, and of course, I will look for the extremities, and I will try to get the whole of the extremities and then see whether the limbs are seen properly. Remember, we all have the habit of taking a fetal, this thing, what do you call, femur length. But then, remember, please eyeball the opposite femur. Never forget to do it, because unilateral femoral hypoplasia is known. That is the reason why you should always look for the opposite. Just eyeball it so that you know because you normally do the near femur measurement, isn't it? So you also look for that, and then look for the alignment with the legs as well as the foot, and then the hands. That's how you look for, and then of course you see the placenta, and then the amount of liquor, come down and see for the cervix. If you can see the cervix, yes and good, but then quite often it is better to evaluate the cervix transvaginally. And then let me try to take a sweep here. I think the amount of Leica is good. Let me see if I can get a good 3D.
One question about long bones, sir. We measure routinely long bones. We measure routinely femur only. What are the indications to measure all the long bones, humerus, radius, and all this
measure, but then you have to eyeball all the long bones. Because once you eyeball, you will definitely make out whether there is any smallness of the eyeball. See, whenever you try to evaluate the long bone or the skeletal abnormalities, there are 4 things that you are going to look for. 1, the size. 2, the mineralization. 3, the molding. 4, presence or absence of any fractures and callus formation. So, and associated with it, the muscle mass as well as the joints. So, this is how you try to evaluate. Am I correct?
Yes, sir. Sure.
Yeah. Right. Let me see. Hopefully, this has been a very, very good baby. I thought I will give her a good facelift. I am just trying. Yes, please. Put it down.
Okay. और एक केस है शायद और एक
No, yeah. Take it up. Take this one up. Yes, right. Okay. That's right. And increase the beam. Now rotate a little bit. No, this way, axis. This the opposite. Still further. Yes. Now cut this one off. Yes. Now this is not good. I won't accept this. Okay, I'll take one more sweep. Take it. No, reduce the bones. Take it to the face. Right. Take it. This baby is shy, putting its hand across the face. Can you see that? Yes?
Yes, sir.
See? Yeah. Okay. Very good. Okay. But anyway, this is let us take one spine.
Yes.
Skeletal, bone. This is just I am just a little playing with it.
Excuse me, sir.
Yes, sir.
Can you please demonstrate gallbladder once again?
Yes, sir. I'll show you. I'll show you. I'll positively show you. Anyway, okay. This is the stomach of the fetal heart. Okay. Agreed? Now I am coming down to the abdomen. Can you see that is the umbilical vein, porto-umbilical junction? Just below, that is the gallbladder. Can you see that? Please. Show it. Show you that. No. Yeah, that is the one. Can you see that one? Sorry. Okay? Happy? Who has asked that question? Are you happy? Not happy?
Not yet. Can you put the mark on that, sir?
Oh, okay. Sorry. This is the one.
Right.
Can you see that? Now?
Thank you, sir.
Yes? You are happy. Now, I will show you how I got that.
Sir, there is a question.
Yes.
So, will you please show us how to go to the plane of perianal muscle complex?
What is it? Oh, yes, I'll do that. I'll show you. Oh, sorry, I should have done that myself. I'm sorry. Yeah. So, okay. This is the bladder. Agreed? Hello? Yes, no?
Yes, sir.
Yes. Now I am sweeping it down, pushing it up. Yes, freeze it please.
Yes.
Yeah. You are slow, it won't show, wait till then. He's a very active, smart kid. No, I'll do it again. Don't worry. One second. Okay. Now. Okay. Please. Yes. Yes.
Ah, yes.
Okay.
Yes, sir.
Right? Yes. No. Very
Yes,
good.
sir. Thank you, sir.
Can we take a sweep there? I'll demonstrate the anus very beautifully. Small, very small. Small. By the time you do that, it goes off. Do it. Take it. Yeah, no. No. Increase the gain. Where is the gain? Leave this one. Show me that. I'll try to manipulate that. Where is the walkthrough? This one? No, it's not good. No, I'll take it again. Once again. No, what you need to do is you take it this way. This way. Right. Take it. It's anyway, don't worry. It takes time.
So what is the importance of looking at this PSMC,
Pardon me?
perianal muscular complex? What is the importance of looking at this PAMC? And from what gestation we should be able to see this?
Which one?
PAMC.
See, normally you can start seeing it from 18 weeks onwards, but it is usually very difficult between 18 to 20, but from 20 onwards you can definitely see.
So it is a must-see thing in your routine
Not a
anomaly
must.
scan.
Actually, any of the guidelines have not included it right now, but I think it is better to see. No guideline has included it. Okay, shall I stop?
Sir, can you again show the equal to sign, please?
Pardon me?
Equal to sign.
Equal to sign of what? There are
In
many
the,
equal tos.
in the palette. Uvula.
Uvula, okay.
Yes.
I'll try. Actually, I had a wonderful experience last time when I came, not last time, before that, when I came to Sholapur. They have got 3 cases and all the 3 had congenital abnormalities. Wonderful abnormalities, and that too, one was a ventricular arterial discordance, one was a TAPVC. And I requested them to give me feedback, no one gave me feedback. Okay, now see. Can you see the tongue?
Yes, sir.
Yes, sir.
See that uvula. Oh. Yeah. See this.
Okay.
Yes, sir. Nicely seen.
I'll show you. See, beautiful. See this one? Can
Yes,
you
sir.
appreciate
Yes.
now?
Yes, sir. Yes.
Right.
Okay, sir. Thank you, sir.
Thank you, sir.
So
That
one
is
question about PAMC.
Pardon me?
What is the importance of seeing the PAMC?
What is the importance in sense if suppose you don't see and you see an anal raphe, positively you are dealing with an anal atresia. Because see, quite often the anal atresia may not, will not present with hydramnios. Okay.
Yes,
Only
sir.
thing is there can be some amount of distal colonic distension, and in that situation when you don't see the PANS, that is the perianal muscular complex, positively you are dealing with an anal atresia. Am I okay?
Sir, can you demonstrate aortic isthmus?
Pardon me?
Aortic isthmus.
isthmus. One second. One second, just little bit, it's okay. Can you just do the same exercise? Decrease the. Right now, put this spectrum. No, just directly spectrum. I don't want the color. keep it, you take the sample. Yes. Oh, sorry. Yeah. Can you see this? That is the, now do you know how I got it? I got the 3 vessel view. Okay?
Yes,
I'll
sir.
show you once again. Shilpa is helping me. So this is the iota. One second. Wait. Yeah. It has moved. Okay. It's okay. No problem. That is this short. Very good, baby. Right. Come on. So, yes. Could you get it now?
Yes, sir.
Yes. So, 3 vessel view. Identify the ductal arch. Put your sample there. Am I clear?
Yes, sir.
Yes, no? Yes. Very good. The other way around is to do a sagittal section, but then I don't like that. It's very different. So, this is the, what is this? I must show this one. What is this? What is this aorta? Come on. Aortic arch. Then what about this? What about this? What about that? Very good, ductal arch. And then, see, you are very good. I know Sholapur people are very smart. Now, I am trying to get the bicable view, but then I am not. Anyway, let us see. Yeah. Can you see this?
Yeah, this is the perfect bicable view.
Bicable view?
Yeah.
Please. Show them. That is the superior vena cava, right atrium, that is the inferior vena cava. Okay? This is what is called as a hammock view. Hammock.
Yes,
you know
sir.
hammock?
Yes.
Yes, that you know. Good. Yeah, what is it? Again do it. Another case. Yes. Oh, okay. Yeah. Okay.
Sir, one last question is there.
Yeah.
It is essential to visualize open hand because a persistently closed hand is a marker of trisomy 18 or arthrogryposis. So is it sufficient to see one hand or both open hands should be seen?
No, I mean preferably both. See this. I mean just wait for some time, but then see even this is enough. This is fine. See, you can see both the things nicely. See that one? Okay?
Yes, sir, yes.
See? Can we take a section of the fetal head and try to demonstrate the sagittal section? Mid-sag? Now, what I am trying to do is, see, there are certain situations, beautiful. Now, yes. Now, where is the reference dot? Reference dot is this. How to move that one? It's not moving. Yeah, right. So, can you see this one? This is what is called as the multiplanar imaging. Okay. Now, what did I do? I took a volume of the fetal head in the axial section. This is the axial section. This is the axial section in which I have taken the volume. You can see the the cavum septum pellucidum. You can see the frontal horns. You can see the interventricular, the interhemispheric fissure, third ventricle, cerebellar hemispheres. But then there is some shadowing. Now, that same shadowing is seen here also. Now, when I see, where is the walkthrough? This one, no? Where is this one? Yeah, one second. Now, can you see this one? I am now rotating it in such a way that I have got the, this one, and I am trying to put it at the vermis. See this one? Can you see that? Yeah, and see in the sagittal section. This is the sagittal section. Agreed?
Yes, sir.
Okay, that is the vermis. That is the tectum. Okay, this is the cavum septum pellucidum, cavum septum pellucidum, and that echogenic area is the corpus callosum. You got my point?
Yes, sir.
Right? Appreciate it?
Yes, sir. Surely.
Then clap, no? What to do? Okay. Right. Let us take one baby's face here. No, again hand. Rapid, take. Very good. Yeah. See how nicely the nostrils are seen, ala, upper lip, lower lip, chin. अच्छा है? हाँ, बहुत अच्छा है. Baby smart है. Huh? Right. Very good. Take one sweep of the spine, nice spine. Yes. Yeah.
Beautiful it is.
Beautiful.
Yeah.
Right? You can see the scapula also. So without me asking, you are clapping now. Thank you. I am forcing you to do things. Yeah. Okay. Good. अच्छा है. Yes, sir. I have no problem.
Then they are going to have one coffee break.
Oh, okay. No. I want some water if you can. Thank you. Suddenly I thought it's mind rape. Oh God, you are giving bottles also. Thank you, sir.
The break and coffee, tea.
No. After this is over. It won't. Then we'll go. Sorry. Up now. Huh? Pranam Shinade. Pranam. Yeah. Again. Pranam Shinade. Pranam. Huh? Pranali. Sorry. Pranali. Yeah. Enough. That's enough. Yes. Take it. Okay, we'll take it again. It's okay. Good. Yeah. Enough. See, reduce the thing. Okay, can you see the pleural pericardial fluid here?
Yes, sir.
Yeah. Freeze and that is the one. Okay? Good. And then that is the left ventricular outflow tract. Okay? That is the right ventricular outflow tract. And that is the 3-vessel view. Yeah, see this one? Beautifully seen. Okay? 3-vessel. Agreed?
Yes, sir.
Yes. Yeah, beautiful. Gold is always good.
This kind of special looks good also.
No. Gold is always good. That is the perianal muscular complex. Can you see? Yes?
Sir.
Put one 3D sweep.
ले लो.
Vertical.
Yeah, ले लीजिए. नहीं आया. It didn't come.
No.
Increase the gains. Let it be as bright as possible. No, it won't come. Anyway, it's okay. Don't worry.
There's a high tea break after this case. So, everyone after this case, please go out for tea and some snacks.
That was at that time.
Okay.
Because this seems to be good in terms of position. Even the cerebellum is seen nicely.
See, for this, what we need to do is, which is what's called as the occipitobrygmatic view. If you get the occipitobrygmatic view, then you will get a good section, sagittal section, or else you will not.
Yes, correct.
It's not coming. No. Anyway,
Okay.
good. Thank you.
So with that, we take a quick break of 10 minutes or so. Thank you very much, Dr. T.L. and Praveen sir, for exhaustive session and helping Dr. Shilpa also to take good question and answers. And I am just allowing him to take a coffee so that he can help me also during my sessions, because he is always there to encourage all of us. So thank you, sir, for one of the finest demonstrations ever done by him. Thank you, sir. Thank you very much.
It's yourself.
So everyone is requested to come back after 15 minutes. After this, we will have a session on fetal environment that will be taken by Anirudh Kulkarni sir. The next case that we shall be taking up is about fetal environment and color Doppler. Anirudh Kulkarni sir will be the one taking us forward on this case. Currently, he is Joint Secretary of IRIA and President of SFM Marathwada Chapter. Past President of MSBRI, he is a popular national and international faculty in conferences with already 23 publications in his bag. Author of 2 chapters in textbook of radiology, he is known for his innovative skills developing in ultrasound teaching. His areas of interest are not just urogenital, neck and pediatric ultrasound also, but he is also a film enthusiast and an avid traveler. He is also a reviewer of the urogenital section of the prestigious British Journal of Radiology. Sir,
We will start with this.
yes sir, we shall start with the case. Yes sir.
Good evening. Thank you very much for the enthusiastic response. I really appreciate the amounts put in terms of efforts, organizing everything by SOGS as well as MSBRIA and the local team of Society of Fetal Medicine. And secondly, I would like to make 1 or 2 announcements which probably are equally important from SFM point of view. We have so many enthusiasts who want to become member of Society of Fetal Medicine. As you are aware that Society of Fetal Medicine conducts so many regional as well as national and international programs every now and then in a calendar year. So I would request everyone who is not member at present in the hall to become member of Society of Fetal Medicine. The forms, they are available at the counter. At the same time, if you have already registered for this event, you will get 500 rupees refund for your registration fees if you become SFM member today. So that's the offer for the same. And there is one more announcement from IRIA, that is regarding UltraFest. UltraFest is one of the premium conference all over India with attendance more than 800 delegates every year. This year the theme is urogenital, which is a very topic which is close to my heart. We have 10 national faculties and 1 international faculty from obstetrics. It's a 3 days full packed event. We have already crossed registration in excess of 700 delegates. We have a hall capacity of only 850, so I would request all of you to register for UltraFest, particularly from the radiology fraternity. And specially for this event, that is Saturday and Sunday, we have offer of 1000 rupees, which is off from the regular registration fees for the UltraFest. So sincere request from me as well as from MSBR and SFM for becoming a member of SFM, and secondly registering for the Ultrafest. So thank you very much, and then we will start with the present session. Now as you must have seen, the most difficult part, that is 11 to 14 weeks, has been taken care by Dr. Shilpa, who is my classmate and very close friend. Secondly, the anomaly part is being taken care by Dr. TLN Praveen sir. Now I have been left up with, or I opted for it for that matter by choice, is what is called the fetal environment. So fetal environment more or less during my PG days used to be a job of say 1 minute or 2 minutes. Placenta is anterior, liquor is adequate, internal os is closed, cervical length is 35 millimeter, and that's all. It used to take 2 minutes. But now I have realized that it's very, very important to assess the fetal environment in great detail, because it reflects so many changes which are very, very important for eventual good outcome as far as the uneventful fetal birth is, or the baby birth is concerned. So let's start with the same. Okay. So at presently what you can see is that the placenta is a little bit of notch at the fundus, and the remaining portion is posterior. So we are looking at the placenta, which is posterior. So to locate the placenta, more or less we always go in a longitudinal axis, that is the parallel to the uterine as well as the maternal axis. So we always start from the fundus and go down in a long axis fashion towards the internal os or the cervix, and we look at the placental surface. So now as I move down and use my eyeball technique to look at the placenta, it says that it's along the posterior wall. Now there are another two ways of looking at the placenta. So usually there are two axes which are again parallel to the midline long axis of the fetus and the uterus. That is one on the right side. So I am going from the right side from the fundus, again going down to the lower part, again to the lower part of the fetus, and again on the left side. So on the left side again I am going parallel to the midline long axis and again going down lower down. So these are the two ways in which probably you can look at. So suppose if the placenta is on the lateral aspect, the more the transducer that you go on to that half, that is either right half or the left half, the increasing prominence or appearance of the placenta occurs. So if the placenta is right lateral or left lateral, you can demonstrate the placental substance more prominently as you move your transducers to the respective half onto that side. So looking at this placenta, you can really appreciate that more or less it's exactly fundo-posterior. Now whenever you say the localization of placenta, usually we starts around 16 weeks of gestation, and you can appreciate the chorionic fundosum as early as 13 weeks of gestation. So eventually now everyone has accepted that we are not going to grade the placenta in terms of morphology. What we are going to say is the homogeneity of the placenta, retroplacental halo. These are the two components which are very important in stating that the placenta is normal or not. Now in this individual, what you can appreciate now is that looking at this placenta now. Okay. Marker please. Okay. So this is a myometrial interface. So this is a myometrium, and this is the retroplacental halo or RMT or retroplacental thickness. Now whenever you are looking at any placental abnormalities, when the placenta is anterior lower segment or placenta previa along with any previous multiple scar, you are always searching for what is called as a placental adherence or morbidly adherent placenta, and in those individuals probably you are looking about number one and most important thing is what is called a loss of homogeneity. Now here you can appreciate the overall parenchyma of the placenta is homogeneous. The retroplacental halo or RMT is absolutely normal, and neither I can demonstrate the multiple lacunae or placental holes or placental. So that's the one thing which I am looking at if it is a placenta previa and previously multiple scars. So number one, that is placental location, that is the where is the placenta located. Number two is overall ecotexture in terms of morphology, and secondly for presence or absence of any focal lesion within the placenta. Then third is the looking at the retroplacental halo or the placenta and the myometrial interface. And third and most important in patients with multiple scar is looking at various appearances of retroplacental halo abnormalities or the placental morphology abnormalities in terms of presence or absence of multiple holes or multiple lacunae within the placental substance. So here you can appreciate the placenta is posterior and the liquor looks to be adequate. Now in terms of liquor, now here the presenting part is vertex, you can appreciate very well. Okay. Now secondly, I am going to look at the spine and the axis of the spine. Now here the spine is anterior and to the left, and particularly very important to demonstrate the same in case of third trimester and help the obstetrician where the spine is exactly. And the next is to look for the amniotic fluid. Now in terms of gestational age, which is less than 16 weeks of period, we always look for what is called a deep vertical pocket. So, and in cases of gestation which are more than 16 weeks in gestation, we always look for what is called the amniotic fluid index. Both of them, they are actually the quantitative assessment criteria for assessing the liquor quantity. Now when we say deepest vertical pocket, we need to understand that now you can see I am putting more pressure by the transducers. Can you see the curvature over here? You can see some amount of convexity over there. Now I am releasing the same. Can you see the pressure is gone? Now you need to understand that whenever, now this is not the patient in which you should record the deepest vertical pocket, but I am just trying to demonstrate. Now I am increasing the pressure. You can see the vertical distance is getting reduced over here. The moment I am releasing the pressure, the deepest vertical pocket is increasing in its measurements. So whenever in case of say measuring the amniotic fluid index, as well as whenever you are measuring the deepest vertical pocket, the pressure by the transducer should be as minimal as possible. If you release the pressure in the respective quadrant, probably you will get appropriate measurement as far as the deep vertical pocket is concerned.
Which one is better method, AFI or single deepest pocket?
So it has got two different indication altogether. I mean, in case of multiple pregnancies, we should follow what is called as the deepest vertical measurements or single vertical measurement, or in cases of say patients who are more than 16 weeks of gestation and where specifically the indication is for assessment of liquor, it is always better to assess it by quantitative method in terms of giving the index, because the diagnosis as far as oligo or say can you just make it 4 quadrant?
Yeah, actually there is one important factor is that whenever there is poly, we always go by what is called as the AFI. Whenever there is oligo, it is always better to take the deep vertical pocket, because see the deepest vertical pocket is very, very important as far as the oligohydramnios is concerned. Whereas poly, we want to know the volume of the amniotic fluid. Whereas in an oligo, what we want is, what is it a sufficient pocket of amniotic fluid is available or not. So that makes the difference, and that makes us to choose whether the deepest vertical pocket or the amniotic fluid index into consideration. Anirudh has wonderfully, you go ahead and I'll tell you. You have demonstrated a very good thing like pressure over this thing. I'll tell you what exactly it is.
So next thing is that what I have done right now is that by dividing the fetal abdomen, the maternal abdomen into 4 quadrant, this is quadrant 1, that is right upper, then this is left upper, this is left lower, and this is right lower. So now you can see that the pressure by the transducer is quite minimal one. The liquor pocket which I have demonstrated in respective quadrant is devoid of any fetal part or umbilical cord over there. Now you specifically cannot do this objectively, but eventually you need to understand that whenever you want to measure the same, you need to adapt to the caliber so that the fetal parts, they are not included. Number 1, neither you are including any amount of cords which are there in the specific region, and thirdly, it has to be a vertical and it should not be an oblong one. So the two things which are very important is that number 1 is that you are taking in 4 different quadrants. The transducer pressure should be as less as possible, and thirdly, your transducer should be vertical or 90 degrees to the long axis of the anterior abdominal wall. That means you should not take measurements. Now I will show you one. So this is how we take the index. Now what I am doing is presently is that I am taking now this pocket. Presently you can see that, let us assume that this is a pocket which is approximately say of with a normal technique that I use. Now same thing, now what I am doing is that I am taking a oblique transducer position. Okay. Then here you can appreciate that the vertical measurement of this has suddenly increased to a dramatically to a higher centimeters. So that is not important. So technique in case of AFI is very important. Dividing into 4 quadrants, taking vertical measurement, allowing transducer pressure to be as minimal as possible, and not including the cord as well as not including the fetal part is one of the most important criteria for the same.
So Anirudh, one question, should we use the color box like continuously while we do, because in some fat patients
it's always better rather than I mean there are a few people who say that you put a color Doppler in each window like 4 quadrant window, and then just look for each place where there is a cord or not. But what I usually do is that if I find it more particulate and some kind of a cord-like echoes into those substance, I usually put the color. But definitely you can make a point and use color Doppler in each and every quadrant, so that you are not taking any cord measurements as a vertical measurement in that zone. Agreed, Shilpa? Sir, you wanted to emphasize something more.
I enjoy. You show the placenta. Now, demonstrate the placenta. See, and then use the pressure. Right. Now release the pressure. Right. You can see the separation. This is what is called as the placenta separation sign. This is an article that has been published in December White Journal. See, whenever there is an adherence, this placental separation will not happen.
So it is as good as equal to what is called the sliding sign that we use in rest of the part as far as the cesarean scar.
This is what is called as the separation, placental separation sign. If the placenta separates, it is not adherent. If it doesn't separate, after releasing the pressure, it is adherent.
Yes, this is recent guideline which has. So this is, see, now you can appreciate the biometric substance over here.
Yes.
Okay. Now this is a placental substance over here. Now the moment I am putting a transducer pressure, this is obliterated. Okay.
Yes.
Now as I am releasing the pressure, again we are able to demonstrate the biometrial tissue well, as well as RMT or placental thickness, that is absolutely normal. So if this is present, that means there is no placental adherence. So that's a very good point, sir. Thank you.
And cord insertion also in the placenta is very important for us. Show the cord insertion. You have demonstrated actually nicely.
So there were a lot of studies in terms of assessment as far as the placental thickness is concerned. That is number one. And there were a lot of studies in terms of stating what is a placental volume, what is placental weight, and whether it has got any kind of relation as far as the fetal outcome is concerned. Now this is a placenta, this umbilical cord attachment at the level of placenta. Now it has been proved fact that in patients of growth restriction, the placental thickness at the level of cord insertion is less. And secondly, in patients, particularly in case of infections as well as immunocompromised host, severe anemia, diabetes, and infections, so the placentalomegaly can occur. So usually what the dictum as a gross is that the placental thickness is usually corresponding to
weeks of gestation.
Weeks of gestation.
One question is here for you, sir. How to differentiate between the normal lakes and abnormal pathological lacunae in placenta?
Okay. Now this is normal lake. Okay. Now see the placental holes, which is typically, or placental buttons, which usually typically is called. Now here the size needs to be more than 5 millimeter. Okay. The size needs to be more than 5 millimeter. It needs to be surrounded by normal homogeneous appearance of placenta by more than 75%. So if that is there, then definitely it is placental lake, a placental hole, and particularly they are usually punched out lesions or a non what you can say geographical kind of a distribution in the placental substance. And the remaining placenta in such patients of morbidly adherent placenta is usually heterogeneous in appearance. It is never homogeneous as it is seen very beautifully in this individual. You can see that the placental substance is absolutely homogeneous in
Yes, it is nicely seen.
So put the color on the placental tissue. Yeah.
Yes, placental cotyledon size.
No, so show the hole, at the hole. Yeah. So he has put the color on, and we have the placental lacunae or placental holes, sonal lakes. See, the point is that we need to differentiate between a placental lagoon and a placental lake. Placental lagoon will never have a well-defined outer margin. It is usually diffuse. Whereas a placental lake will definitely have a well-defined echogenic rim. That is one. Two, when you put the color Doppler on, in a placental lagoon, it is a turbulent flow that you find. Whereas in a placental lake, you don't find that sort of a turbulent lake. So these are the points by which you can differentiate one from the other. But basically remember, you are not going to diagnose a adherent placenta or a placenta accreta spectrum based only on placental lagoons. You take all other conditions, all other factors also into consideration, like the lateroplacental complex, and then the myometrial thinning, location, infiltration, all these things are put together. See, beautifully demonstrating the basal layer with the vascularity. So, I mean, there is no reason why you need to think in terms of a adherent placenta at all. So, that's how you are going to take into consideration.
See, whenever we consider placental adherence or abnormalities, we always consider that it has to be in the scar zone. But literature has also mentioned about few of the placenta who are in anterior location and not previa one, but still can have some amount of morbidly adherent placenta. So in those individuals, we need to understand one of the important criteria to say that it is not a adherent placenta is what is called as a vascular flow in the RMT region. Now, whenever you can demonstrate a parallel kind of a vascular flow which is behind the placental substance, which is running parallel to the uterine wall, we are quite sure that this is a normal vasculature pattern as far as the retroplacental complex is concerned. Now, in cases of all patients where there is a morbidly adherent placenta, number one and foremost thing will occur is that there will be inhomogeneous appearance of the placenta on grayscale ultrasound. On color Doppler, you will find that there is a inhomogeneous large size placental lacunae or holes with turbulent kind of a flow. There is abnormality in terms of retroplacental halo and thinning which is less than 1 centimeter on that side. And thirdly, there will be a branching kind of a vascularity which is starting from the placenta, entering into the myometrial substance, and which is perpendicular in nature and not parallel along the axis of the myometrial substance. Now, here you can appreciate that it's going parallel, well appreciated retroplacental halo, which is the RMT value, and which is again more than 1 centimeter, and the placental substance is absolutely homogeneous in nature, which entirely rules out the any kind of adherence as far as the placenta is concerned.
One question is here. Routinely we get PAS, that is placenta accreta spectrum, in when the placenta is located in the anterior aspect near cervix, and there is history of previous scarring, Syrian section, all that thing. The question is, can you get PAS in posterior placed placentas?
Yes, you can. You can, particularly when there are multiple uterine manipulations that have been done, or even when there is a myomectomy that has been done, or most of the times these assisted reproductive techniques where they use embryo transfer catheters, sometimes they can also be traumatic, and that can result in this sort of a posterior adherence.
Okay, thank you, sir.
There is one more case, no? No, see, you have asked few things about the morbidly PAS or morbidly adherent placenta. One thing which is very important is that we need to understand the morphology as far as the lower segment scar is concerned in non-pregnant state and even in early pregnancy, because we need to understand one of the important markers for PAS is low implantation sac, that needs to be demonstrated in early pregnancy. What is meant by low implantation sac? Low implantation sac means implantation of a blastocyst where the chorionic activity margin which is seen in the lower segment, which is less than 5 centimeter from the external os. So, less than 5 centimeter from the external os in the lower segment, it is low implantation sac. Now, in case of a low implantation sac, we need to understand cesarean scar pregnancy, cervico-ischemic implantation, simple low implantation, or cervical pregnancy, which is again a graded condition where probably intervention is mandatory. In patients where there is a cervico-ischemic implantation, it is usually a gestational sac in the lower segment where the lower margin is below the insertion of uterine arteries closer to the internal os. You need to understand that all those patients who presents with a lower segment implantation, that is implantation at the cervico-ischemic region, all this may land up in future with low implantation of placenta and very high probability of having accreta or percreta in third trimester. So, if you are allowing that pregnancy to continue where the placenta, where the low implantation is there are multiple scars are there, it is a cervico-ischemic implantation, that means you are ruling out condition like cesarean scar pregnancy, cervical pregnancy, then you need to be very sure that the center at which the patient is taking follow-up is well equipped with taking care of all the complications of morbidly adherent placenta as well as preterm deliveries as far as the section is concerned. Anything you want to add, sir? Yelena.
One question about location of placenta. Suppose at 24-26 weeks the placenta lower edge is suppose 1 to 1.5 centimeter away from internal os, and patient directly comes at 36 weeks. At that point the head is in the lower uterine segment. We cannot locate the inferior edge. So how to proceed for this?
Now, usually one need to understand is that in all the placenta previa or low placentation, the further follow-up or surveillance has to be always and always on transvaginal ultrasound. So, particularly this is very important from the...
You're saying thumbs up.
Thumbs up, sorry. So, it is very important to understand and know that as sir has rightly stated, the earlier there should not be hurry in labeling that it is a low implantation, low placentation. Now, after the 16 weeks of gestation and secondly in late second trimester, you can start labeling it to a placenta low lying or not. But whenever you want to label it as a placenta previa or in relation to the internal os, if it is less than 2 centimeters from the internal os in early pregnancy, you just label it. As Shilpa has rightly stated, there is a very high probability even anterior and posterior wall that it might migrate or resolution might occur. But whenever there is a covering of the placenta internal os by more than 2 centimeters in early pregnancy, it is unlikely that it will at least be a low lying placenta rather than the complete resolution. So, it is always better whenever you want to comment anything as far as placenta previa is considered, always and always do transvaginal ultrasound. We must train our PGs for the fact that even though it is a placenta previa, the transvaginal ultrasound is always and always safe. Don't worry, your transducer is not going to cause any further harm even though it is a central kind of a placenta previa. So, always tell your obstetrician as well as your PGs that placenta previa, it is not a contraindication for doing transvaginal ultrasound, and in fact transvaginal ultrasound is the only modality where you can grade the placenta, low placentation in a perfect fashion. Now, here in this individual you can appreciate, can we just little bit more. So, one again, what kind of placenta it looks like to be? It looks like to be a anterior placenta. So, again I am starting from the fundic region, again with minimal amount of pressure, there is no depression of transducer. I am going along with the long axis towards the internal os and cervix lower down. The presenting part obviously appears to be cephalic in nature. At the same time, I am just trying to assess where is the spine. Now, again the spine is anteriorly, more or less in the midline. Okay. So, the placenta is anterior, the placenta appears to be, can you just, yes, can you just up the focal zone. Okay. So placenta is absolutely homogeneous in nature. Can you do it dual? Okay. Increase the window. Okay. Now in terms of, so the homogeneous appearance of the placenta is well appreciated. You can appreciate the vessels here towards the amniotic side as well as towards the myometrial side. The entire placental substance is absolutely homogeneous in nature. Okay. Now here I am just compressing it as sir has stated. Now I have completely obliterated the myometrial or the RMT over there, and I am now releasing the pressure. Now it is again reappearing. That means there is no signs of placental adherence in this placenta. I am going below. Again the placental substance is absolutely homogeneous in nature. I can see the the cord attachment over there. Now coming down to liquor, can you reduce the zoom please? Again in 4 cord. Okay, so this is the right upper quadrant. Can you reduce the depth? Okay, so again long axis, the transducer pressure is very less. The right upper quadrant, then the left upper quadrant, the left lower quadrant, and the right lower quadrant. Okay.
Anirudh, how did you get these quadrants?
That is the maternal abdomen. I mean,
yeah, how? I mean, I don't know how to get the quadrants. Tell me.
So basically, the long axis is going through the mid abdomen. It goes.
That is the
towards
linea alba.
Linea alba. That goes towards the pubic symphysis, and the second plane is going through the umbilical. That is a transumbilical.
Yeah.
So this transumbilical plane will divide the maternal abdomen into 4 quadrants. Right upper, left lower, and right lower.
Yeah, because Anirudh knows it very well. We better know from him.
Okay. So again, depending upon the we are going to take only vertical measurements. We are going to avoid the fetal parts, and fortunately we don't have any cord at present. But as Shilpa has stated, we can always put a color Doppler in each and every quadrant. And look for any cord. So you can put a color Doppler there and see whether there is any cord or not. So this is how you go about as far as the.
It has a very good color perception, no?
Yeah.
This one, this machine.
Now, the application guy along with myself, so both are working on the same field. Not great people. I mean, one trying to help each other. But the second thing is that because I am used to the machine, so that quality is good. So that's one of the reason I am used to this machine.
One question about placenta. We come across a few reports which use the word jelly-like placenta. What is it? Jelly-like placenta.
I have not heard. What is that? Please let me know.
Jelly-like placenta means, you mean to say any abnormality as far as the morphology is concerned?
Yeah, the appearance is jelly-like.
I mean, how can it be? Jelly is to be felt. It cannot be seen.
I have come across few reports like that. It is given in literature also.
So to my knowledge, you can highlight the same if you have some additional information for all of us.
Because I have no idea. I mean, but
in literature it is associated with FGR babies, and only finding is the appearance of placenta is jelly-like.
So it is basically the jelly-like placenta is a hyperinflated placenta. So that condition is that where the lacunar spaces are filled by the maternal blood, and the exchange of the villus at the level of villi is not proper. And when these placenta, when you see that in the fetus they are thick, hyperinflated, like the thickness is more than 5 centimeters, and when the patient means the baby is delivered, and when this placenta comes out, the venous blood which is from the maternal side, it goes off and the placenta becomes very thin and that not that thick. So it is probably the hyperinflated placenta which you are telling. It is associated with preeclampsia and FGR. A very thick placenta associated with fetal growth restriction and oligohydramnios.
So Shilpa ma'am might have come across such cases. I think she has seen so many cases.
In terms of just to have something more. Now there are various kinds of abnormalities as far as the cord insertion is concerned. So whenever there is an abnormality in terms of cord insertion is concerned, it could be filamentous insertion. And on many instances in the placenta previa, there could be a abnormal presentation as well as abnormal cord insertion in those individuals, which needs to be reported very dogmatically, because that will decide the manner in which the sectional outcome will be there, and they will take care as far as the placental retrieval is concerned after delivery of the fetus is there. So it is always better to report them aggressively whenever you see those abnormalities. It's very, very important.
So particulate amniotic fluid.
See, particulate amniotic, see, if I increase the gain on many instances, you will find. So it's always, so most of the machines, they have got what is called as auto or eye touch. Now here, as soon as I put the eye touch, the particular thing is gone.
No, in spite of eye touch, I find particulate.
So if it's a particulate liquor, then you need to look for.
What are the, that's what I want to know.
Usually in case of.
Oh, he's changing the whole thing.
No. So he thought that there is something wrong as well. It's just question and discussion.
See, there are various causes. Silva, you want to say?
I like to welcome Dr. Bimal Sahani to the auditorium. He's just arrived, and special, sir, warm welcome to you. Yes.
But how come he is allowed when he is supposed to come tomorrow morning at 9 a.m.?
Ask him to go out.
Sir, a special permission.
With special permission from whom?
Boss is here.
Okay, sir. So, welcome Dr. Bimal Sahani, sir, and really appreciate his presence. Now, the reason why he is here is because he has seen few of the photographs where the entire hall is completely full packed with 200 audience, and people are enjoying all kind of academics. So he always feels that he is left out from this wonderful opportunity of interacting with all the delegates. So give a big round of applause for Dr. Bimal Sahani, that he is such an enthusiastic guy that even though along with his family and his friends he was enjoying in Latur, he immediately see to it that he reached to the hall full of audience, full of energy, asking so many questions through the media of Dr. Sujit and Dr. Sharma. And thank you, Dr. Bimal Sahani, for coming down here and appreciating the amount put in, the efforts put in by SOGS and MSBRI in conjunction with the SFM chapter Solapur.
So here.
Thank you so much, sir. Thank you for welcoming Bimal Sahani, sir.
So, sir, here are two questions on liquor. Can you suspect meconium stain liquor on in third trimester if you see the particles, ecogenic particles in liquor?
There was one study which said that the particle size, but eventually I don't think people have accepted it beyond just a research purpose. But regarding particulate liquor, sir was about, where is? Yes, you can.
See, particulate liquor, the various implications that we have to think in terms of are, one is that it could be an amniitis, that is infection of the amniotic fluid. Two is hemorrhage into the placenta, into the amniotic fluid. Three is the meconium stain. Four is the vernix caseosa. So these are the factors which will produce what is called as the particulate amniotic fluid. So, but then see, all of them, there is no way that you can differentiate one from the other. Taking history into consideration, if there is any trauma or any cause for or anticoagulants that the patient is being taken, you find an amniotic fluid which is particulate, then you definitely think in terms of a hemorrhage. If the patient is having fever or some sort of a stiffness of the abdomen, then you need to think in terms of infective pathology. Of course, whenever there is the meconium stain, usually in the late nearing to term, you may find this sort of a particulate material. So these are the various things. It's only things that we have to discuss about it whenever there is a particulate amniotic fluid.
Thank you, sir. Another question is the term oligohydramnios is usually used in second or third trimester. So what is oligoamniotic sac in first trimester?
Oligoamniotic sac in first trimester, you mean to say?
Yes.
Okay. So if you are unable to put one more CRL into that same zone of gestational sac, probably you are dealing with oligoamniotic sac. And secondly, it's more or less eyeballing rather than any quantitative estimation as far as the any quantitative estimation is concerned. But usually it says to be one of the poor prognosticating criteria for eventual failed pregnancy, but you need to follow the Peter-Douglas criteria for the presence or absence of activity with CRL criteria and gestational state criteria. Finish.
Sir, one question. Hello.
So the CRL, MSD minus CRL, if it is less than 5 millimeters, if you objectively really want to say that yes, this is first trimester oligo, then if it is less than 5 millimeters, then we say that it is first trimester oligo.
Hello. Hello. One question, sir. It is regarding the appearance of the amniotic fluid. Can we predict from the appearance of the amniotic fluid about the lung maturity of the fetus when it is between 33 to 34 weeks?
Initially, we used to say that depending upon the particulate, depending upon the coarse appearance of echogenicity as far as the liquor is concerned, we used to say that pulmonary maturation is present. But eventually, now that theory is more or less is not accepted. We always rely upon other indicators. So isolatedly, only particulate liquor for meconium stained liquor, or only stating that it to be a pulmonary maturation doesn't valid in nowadays as far as the lung maturation is concerned.
One more thing which I would like to remember is that ichthyosis is one thing where you will have this particulate material within the plaques. So that is one thing which you have to keep in mind.
Now in the same patient, the vessels we can Dr. Bimal Sahni sir ने बोला था बोलो.
So we will move to Dopplers now, multi-vessel Doppler.
Sir, before Doppler.
Dr. Bimal, there is a demand that Dr. Bimal Sahni sir should take one or two questions, because Dr. Shilpa is going to demonstrate the few of the vessels of third trimester. So Dr. Bimal Sahni sir, can you just
So we are demonstrating basically is a Doppler in front of Bimal sir is like demonstrating something, a student is demonstrating something in front of principal. So, okay. So now when we come to the Doppler, which is the important thing in the third trimester. So the most important thing in the third trimester is that all the growth scan, we have to take the Doppler examinations, and in the Doppler examinations, what is the main indication is basically we have to identify the FGR if it is present or not, and then we have to prognosticate that how long the fetus is safe in the maternal abdomen. For this, the Doppler becomes very useful for us. So for this, first we will be going for the MCA. So how to take the MCA? So basically we have to go, this is our BPD section, and from that we have to go slightly down at the level of circle of Willis, and then we have to identify the circle of Willis, and from that the middle cerebral artery arises, which is a branch of the internal carotid artery. So this is the middle cerebral artery here, and then we have to take the spectral spectrum of this. Now where we are going to, there are certain things which we need to identify, or which we have to follow before taking the MCA Doppler. The most important thing which we are going to do is we are going to keep a very, very light pressure. The moment you increase the pressure over the anterior frontal, we visualize all these vessels through the anterior frontal. So when you give lot of pressure in, over this, the MCA which get compressed from the pressure on above and below, there is a sphenoid bone. So in between these bone it becomes compressed, and if it is an abnormal MCA with an increased diastolic flow with your compression, that will, the flow will become normal, and then it will be a false negative thing. So we should apply a very, very light pressure over this. And secondly, where we should keep the angle of insonation basically should be almost near 0, the vessel direction. And then we have to take the measurement in the proximal part of this. Yeah, here we are going to take the measurement. अभी मैं आपको मैं बोलूँगी ना, तब सांस जैसे में से रोक देने का, पेट की हलचल एकदम वो इसके लिए 3 सेकंड के लिए रोक देने की, ठीक है? रोक लीजिए सांस, छोड़नी की नहीं सांस, छोड़ दे. So this is what is the normal spectrum. I'll try to take another spectrum. So this is the peak systolic velocity, this is the diastolic velocity. In the MCA it is a high resistance flow, and therefore we get a low diastolic velocity in the MCA vessels, and when there is hypoxia, basically these vessels dilate, and therefore the diastolic flow increases and then the PI decreases. So this is how we have to identify the vessel. We have to take the vessel in the measurement. We have to take the MCA Doppler at this level, just in the proximal part. If you take in the higher, in this distal part, then the vessel parameter, means the parameters slightly get altered. So this is the position where we are going to take the MCA. With a very light pressure we have to take these two important things we need to demonstrate.
One question is here.
Yes.
In respect to cerebral perfusion, why do you choose middle cerebral artery and why not anterior cerebral or posterior cerebral artery?
Because middle cerebral artery has a very, it is well supported by the sphenoid bones, and therefore like this vessel doesn't, means that is a thing which is chosen more. Yeah, Bimal sir wants to answer.
See, basically there is extreme variation as far as the anterior one and the posterior communicating one, and even the subjective variation as far as the measurements of PI values of those individuals, those vessels are concerned, is quite variable one. So that's the vessel which is well supported posteriorly. It's a short straight segment of MCA which is always available. We try to take the most precise and correct measurement as early as possible, because we don't want to put more amount of heat or more amount of energy into that level. So just be sure in a dual mode that you are taking a correct segment of MCA, your velocity setting, angle isolation to 0 is well adjusted, and then you put a spectral Doppler so that you did not repeat those measurements every now and then, so the amount of energy and heat to the temporal bone and MCA vessel is as less as possible. Thank you.
One more reason is that the pulsatility index in anterior and posterior cerebral artery is naturally low. So if you take it as middle cerebral artery and put in your report, you are falsely diagnosing brain sparing effect. This is another reason.
Okay. So now this is one vessel MCA. Now we come to the
as regards the MCA, one thing you should be very clear about is that, you have to just, you just don't need to keep doing it again and again. So you have to use the principle of Alara, because MCA flanks the greater wing of sphenoid, and the greater wing of sphenoid is a very, very fragile bone. And the amount of energy which is produced on a PW Doppler is the highest as compared to the grade scale and the routine color that we do. So you just need to get a few good waveforms, and that's more than sufficient.
Now we come to the umbilical artery. So as we know that umbilical cord has 3 vessels. Now where do we take the umbilical artery? So there are guidelines of ISCOG which tell that we have to identify the umbilical artery and take the spectral waveform measurements at the free loop of the cord, neither at the fetal insertion of the cord, neither at the placental insertion of the cord. So we have to take a free loop of the cord. Why? Because at the fetal end the PI values are, the resistance is high, therefore the PI values go high, and at the placental end the PI values are low, and therefore we have to take that in the free loop, usually in the singletons. But when we take that in the twins, they say that you should identify that at the in fetal insertion, because for follow-ups and other things, that level measurement at that level becomes very important, and that in serial follow-up the measurement should be at the same level. Therefore in twins it is recommended that they are to be taken near the fetal abdomen. So here in this free loop, okay. So these are the indices where the PI is 0.77. So as the pregnancy advances, basically the umbilical artery, it is a indication that how the resistance is there in the placenta. So as the pregnancy advances, the placental flow increases, the resistance decreases, and therefore the diastolic flow in the umbilical artery increases. But basically the diastolic flow tells us how is the resistance in the periphery where the flow is going. So the resistance in the periphery, that means the placenta here, is low, and therefore the PI becomes high. So this is a normal flow in the pregnancy in the later trimesters where the diastolic flow goes on increasing.
I would like to ask the audience, uterine artery is a placental vessel. What about umbilical artery? Is it a placental test or is it a fetal test? How many of you say placental test? And how many of you say fetal test? Okay, so all of you, most of you say it's a fetal test. Actually, it is not a fetal test. It doesn't tell you anything about the fetus. That is exactly what Shilpa was saying, that it is telling you about the peripheral vascular resistance at the placental test. So it is not telling you how the fetus is coping with the adversity. It is actually telling you about the resistance at the placental level. So both uterine artery and umbilical artery are basically placental tests. They are not fetal tests. MCA and ductus venosus, these are the fetal tests which actually tell you how is the fetus coping up with the adversity that has occurred. Yeah, Shilpa, you can continue.
One question about umbilical artery waveform.
Yeah.
This happens many times when we take umbilical artery waveform, it is abnormal. And after 24 hours, we call the patient, and next day it is totally normal. What are the factors influencing it, or how to interpret with this, these types of results?
Yeah, first of all, anytime you find any abnormality in a fetal scan, make sure that you confirm that. See, if a patient is coming to you for an abdominal ultrasound for pain in abdomen, patient is coming to you with history, and there is a symptom, and everything is expected to be abnormal, whereas in pregnancy everything is expected to be normal. So whenever you feel that there is something abnormal, you be better sure of that. And as regards Doppler, that's the most important thing, because there are so many things which can influence a Doppler waveform. Like for Sujit's question, if you have a cord which is just stuck up between the head and the placenta, you may find that you're finding absent diastolic flow in umbilical artery. Your wall filter, if your wall filter is set at a wrong if it's set too high, all the low velocities will disappear and you may falsely get an absent diastolic flow. So whenever you get this, always turn the patient to a little side so that you remove this, the cord compression anywhere which is occurring between the fetal head and the uterine wall or the placenta. So you can always turn that. So that is one reason where you get that. Now, one thing which nobody talks about, and even the literature doesn't talk about much, maybe I think my own publication will come on that soon, is the heart rate actually affects the PI very much. So, if the fetal heart rate is high, the PI is actually inversely proportional to that. See, we normally expect the fetal heart rate, though the range is huge from 120 to 180, the normal heart rate, but then normally we find that the heart rate is around 140 or something. So you always see that. If you find that there is so when you take the measurements, also look at what is the heart rate which is coming. If the heart rate is coming to about 160, 165, wait for some time. Or fetus has just moved, so that especially with MCA, because all your CPR and everything will get abnormal if your MCA that you have taken is wrong. And that is why the fetal heart rate, if the fetus has just moved, give it some time, let the fetus settle down. That is something you all try from Monday morning and see. You will realize the difference. You see a fetal, the PI at a fetal heart rate of 140 at 160, and 120, and you will find there is a difference between all that. So, if, that's why it's very, very important. We all talk about Barcelona and all those staging and everything, but there is a fine print there which says that to be repeated after 24 hours. So if you find an abnormality and if it is still present after 24 hours, that is the time when we give it significance. Of course, you have a complete picture that you are dealing with an FGR and all, then you won't require, but otherwise you need to reconfirm after that. So simple things, just turn the patient on one side, repeat the scan, let the patient wait for some time and then repeat it. Always you can take an umbilical artery PI of both the vessels, and the one which is closer to the normal is the one which you need to take into consideration.
One question about CP ratio. All the Barcelona guidelines staging is applicable for and CP ratio abnormalities are applicable for FGR fetuses. What is your take when the CP ratio is less than fifth centile in AGA fetus?
See, CP ratio is something which is a very important thing, but at the same time, it is something because of technical reasons you may I would be very, very cautious if I find an abnormal CP ratio in a AGA fetus. See, first of all, we know that yes, AGA fetuses can also be fetal growth restricted, that yes, 10 centile is not universally correct, but then we would be very, very careful about using that. So if I find a AGA fetus with a CPR which is less than 5th centile, I would recommend that everybody should see the patient after an hour or so, call them next day morning and confirm. Because usually in the 3rd trimester, we don't expect the CP ratio to become abnormal because of the umbilical artery. It usually becomes abnormal primarily because of the MCA, because the brain is the one, it becomes very responsive to hypoxia in the 3rd trimester. And hence you repeat that, and if you find a CPR which is still low, that is a patient, even though if it's AGA, I would put them into a follow-up.
Few questions regarding practical problems with the MCA. Many times because of the liquor or fetal position, if the head is extended and you don't get the proper MCA, then what is the next vessel to compare with the umbilical artery?
As regards
CP
CPR,
yes.
CPR.
Yes.
No, CPR means I have to get the MCA. CPR is a ratio between the, it's a cerebroplacental ratio where we take the MCA and this thing. So it is not possible that we will eventually not get it. We just need to wait and you will get it. There is no issue about that.
Okay. If we are only interested in PI of MCA, is it necessary to keep the angle of isonation to 0? Or
it is not necessary. It is not necessary because we are dealing with indices. Yes. Only place where it becomes
PSV.
when you are looking at the PSV. But first of all, naturally, the MCA is the vessel which gives you an angle which is closer to 0, because you're always taking your BPD in an axial section and the MCA is perpendicular to the midline falx, and so you will always get an angle which is closer to 0. And yes, I won't go about correcting the angle, but if required, another thing is if you have a good angle, you will get good crisp images. Yes. The quality of the waveform that you get is good, and hence your readings are very, very correct.
And in multifetal pregnancies, if we see umbilical artery by the side of bladder, is it okay?
By the side of?
Bladder.
See, you can see umbilical artery wherever you want to, but then you need to use a normogram which is meant for that particular thing. I have recently reviewed an article which is used, where they have used the umbilical artery by the side of the bladder, but then the normograms are going to be different. This is what Shilpa said, that the PI at the, if you want, you can use the PI at the fetal end or the placental end, but then you need to use a normogram. The normograms which your machines are giving, or the ones which we usually follow, are the ones which are done on a mid loop.
Okay. Thank you, sir.
Yes, Shilpa.
Yes. Now we will be demonstrating the ductus venosus. So ductus venosus is so this point of aliasing which you are visualizing here is the hepatic vein. So basically ductus venosus is the vessel where
Which section is better for ductus venosus visualization? Axial section or this sagittal section?
So in the axial section I always feel, because you know you see how the ductus venosus goes.
In the first trimester,
vessel basically.
yeah, in the first trimester, yes, you go into the sag and do it, but in the third trimester, you generally take a transverse oblique. You take a transverse oblique. Of course, if you're getting a wonderful sag and then you're able to document the umbilical artery, and then it's okay, but then otherwise we use a transverse oblique section in the third trimester.
First we'll look for the uterine arteries now. The same, in the first trimester I have demonstrated how to use the uterine arteries, but now in the third trimester we have to look for the iliac vessels, and then the uterine artery is to be taken, the sample is to be taken in when it crosses the iliac vessels, and the sample should be placed just when it crosses, and at this area the sample should be taken. Now, is there any importance of the increased uterine artery PI in the last trimester, and should we take the uterine artery PI in this last trimester? So, a few studies say that if the uterine artery PI is more in the last trimester, then it is associated with a late poor neurological outcome in the early childhood. So, whenever your uterine artery PI is altered, then you have to like mention that in the report, and again in means in diagnosis of FGR it is again important.
One question about role of aspirin. We usually start aspirin when the mean uterine artery PI is more than 95th centile. So in some cases at 20 weeks, 22 weeks the mean uterine artery PI is normal, but at 28 weeks it is high, more than 95th centile. So in these cases, do we start aspirin? Does it help?
No, it won't help in the aspirin, because basically the aspirin, it acts basically before the second stage of placentation is over. So in the first stage of placentation, which occurs between 8 to 14 weeks, and the second stage which occurs between 14 to 18 weeks, the role of aspirin is very important. But still it is recommended it is still given, so it is proposed that it may prevent some micro thrombi and these things, and for that purpose it is recommended. But the role in reducing the preeclampsia either in late on even after more than 37 weeks, it is not that much useful.
Thank you ma'am.
So we have to again take uterine artery PI of both sides, and then we have to take the mean PI and then and then give the average PI. So let's go to the last vessel, the ductus venosus. The spine is anterior, so we are trying to take in a parasagittal view.
The most important thing while doing Doppler is that you have to take your Doppler waveforms when the fetus is quiet, neither breathing nor moving. Now, majority of the times when a patient comes for a second opinion because of an abnormal Doppler, and I have noticed actually the waveforms have been, the PIs have been taken on a waveform an erratic waveform where probably the fetus was breathing or there was some hiccups or something, and I think that is the kind of patience that you require. There are times, sometimes continuously once the breathing movement starts 30-40 seconds, so you need to have that kind of a patience, wait for the fetus to become quiet, wait for the breathing to stop, and then you take your waveform, and that would be the correct way of doing it. There she's got the ductus venosus.
Yes. So now, as Bimal sir had asked you, what is the placenta, means umbilical artery and the uterine artery? These are the placental tests. The uterine artery is the supplier, the umbilical artery is the extractor, which they give you the status of placenta. But this MCA and ductus venosus, they give you actually the how the fetus is coping with the reduced blood supply which is coming to the fetus. So these are the fetal tests. And ductus venosus is absolutely very useful vessel in the early onset FGR, because ductus venosus basically tells you what is the condition of the right sided of the heart. In fetus there are two parallel circulation against which the right and the left heart are working. The right heart basically is working against the placental resistance, and the left heart is basically working against the cranial resistance or the brain resistance. So when the placental resistance gets altered because of placental disease, it reflects more on the right side of the heart. The right ventricle fails, the right atrium fails, and then the ductus alteration occur. And the A wave depression, reversal of the A wave indicates that yes, this heart is failing and that the acidosis have set in. So ductus venosus evaluation is very important to state the condition in the early onset FGR. Bimal sir,
DV is an abnormal ductus venosus is the critical endpoint in early onset FGR. In early onset FGR, these fetuses are small, and these fetuses can tolerate hypoxia for a very long period of time, and hence it gives enough time for the heart to work more. So there is hypoxia, and so the heart works more and pumps, and eventually the heart starts failing. Now, in early onset FGR, we are dealing with a premature baby. So we know that we don't want acidosis to take place, but at the same time, we don't want to deliver a too premature baby. So either way, it's going to be bad for so that is where when you are doing that balancing act, you start using the ductus venosus as the critical endpoint, especially, if I'm dealing with an early onset FGR at 27, 28 weeks, I am not going to deliver the baby even on an absent diastolic flow in the umbilical artery or a reversal of diastolic flow in the umbilical artery. I will wait for the ductus venosus to become abnormal so that, preferably not wait till reversal eventually takes place. But then, of course, you require too much of monitoring. You require monitoring maybe twice a day, and then because that every day that you give the fetus inside, you are actually reducing the morbidity in early onset FGR. In late onset FGR, yes, ductus venosus, we are not using ductus venosus as a critical endpoint to deliver, because after 30 weeks, 32 weeks, yes, even if you have an abnormality in the umbilical artery, like an absent diastolic flow or a reversal of diastolic flow, yes, you can take a call on getting that baby out. That is the time you're not going to wait for the ductus venosus to become abnormal.
One question is there. Is it necessary to look? Yeah, this is the last question. Okay. Is it necessary to look at ductus venosus in each and every patient, or you go for it in selected patients?
See, as a part of a multi-vessel Doppler, you can do everything, but then I would still restrict the use of ductus venosus for, if I find that there is an abnormality in the umbilical artery or the MCA, then yes, I would definitely go ahead and do a ductus venosus. But if I'm finding umbilical artery, MCA, CPR, everything normal, then I won't go about looking at the ductus venosus. But then, yes, it is, if a patient, you're going to do a Doppler, you can do all the 5 vessels, because the ductus venosus definitely tells you about the cardiac function.
Thank you, sir.
Thank you very much. With that, give a big round of applause for Dr. Shilpa, Dr. TLN Praveen, and the entire team who conducted this workshop. So I would request Dr. Vaibhav Meru to just inform us, whoever has taken a lot of efforts in making this. First of all, big thank you to all the patient and relatives. I mean, without the patients, it would not have been possible. Really wonderful to cooperate in these difficult circumstances. So to start with, big round of applause for Dr. Vaibhav Meru. who has put in all his efforts in terms of bringing the patients and making this workshop wonderful and possible to all of you. Dr. Jyoti Tapadia, professor from Dr. Ashwini Hospital. Thank you very much, madam, for all your valiant efforts. Then Dr. Anjali Jamma madam, I think she was quite helpful in last two weeks or so in making this event possible, and special efforts in terms of bringing the cases for all this workshop. So a big thank you to Dr. Anjali madam, then Dr. Monica and Dr. Supriya and Dr. Nanda. So all of them, they really worked very hard in making this workshop a wonderful workshop. So again, Dr. Anshu Sharma, who conducted the program in a what you can say most wonderful and sophisticated fashion to understand to the audience. Dr. Sujit, who made it more interesting by asking so many questions, and many questions he himself answered to us. And again, big thank you to Dr. Bimal Sahani for making it on a very quite short notice and available for all of us to put his own thought of wisdom during the workshop. So one and all, thank you all the audience. Because of you all, probably this event was successful. So big thank you, and have a wonderful evening. Tomorrow morning we will be starting at 9 a.m. sharp, because we have a very exhaustive session as far as all the academics is concerned. So have a great evening, so and please, let us meet once again at 9 a.m. Please.
So on behalf of all the attendees and the participants, I would like to invite Dr. Manik Gurram, Senior Gynecologist, Chairman of Markandeya Rugnalaya, and who has been attending this live workshop since 3 p.m. today. I request sir to propose the vote of thanks.
Thank you, thank you.
I am here to thank. This was a very good academic insight, without lunch and without banquet, but only academics, and that is needed. With very crisp images, live demo throughout explanation, while live ultrasonography. I thank Dr. T.L. Praveen sir, Dr. Shilpa Satalkar madam, Dr. Aniruddha Kulkarni, and Dr. Vimal Sahani sir, and Dr. Sujit Konkar, and MSBRI Solapur branch, Solapur Obstetric Gynecology Society, all the delegates, and all the patients who came here for the ultrasonography. See you tomorrow. Thank you very much.